السلام عليكم.
وعليكم السلام ورحمة الله.
Okay. What time are we supposed to start?
عليكم السلام ورحمة الله دكتور فريد. نبدأ إن شاء الله 1:05.
Okay. أنا هاخذ من وقتكم بس يمكن 10 دقائق أو كده.
أبدا خذ الوقت اللي تبغاه دكتور.
جزاكم الله خير. Just to go over this, how to open this site and how to do it. I have يعني not much experience. It's gonna go beyond يعني with some information يعني to be handled. But we expect some errors. We expect some feedback from you. The most important feedback I would like to see if you see any errors in the question, or if you think that this question is unfair for you to answer. Okay, so those can go under the heading of challenges. We'll try to open it anyway. What I'd like to do is invite everybody to open the link they have. You should have received an email with password and things like this, so each one of you can open and follow how can we go through it once.
السلام عليكم.
السلام ورحمة الله وبركاته.
عليكم السلام.
Good afternoon, everyone, and welcome to our academic activity. So today we'll start by a quick demonstration about the new formative assessment of cardiac surgery to be demonstrated by Dr. Farid Khougir, and then we'll start our lectures, first by mitral valve repair by Dr. Rasha Baqais, and then we'll have another lecture by Dr. Ismail Hamamsi about aortic valve intervention. We are glad to have Dr. Mohammed Rashedan, who's a consultant cardiac surgeon in King Fahd Medical City, to be with us today. Dr. Farid, if you are.
Okay, thank you, Luai. And Welcome aboard, Dr. Rashedan, and hopefully we'll all gonna have a very nice day today. I'd like to ask each one of you if you can open your computer on the website that you have received an email about the formative assessment with its password. So we can follow each. It should look like in the beginning, just like this, with your name, email, and your password written there. Okay. So we'll go ahead and start. Please, if you have any question or anything, stop me at any time.
Dr. Farid?
Aywa? Yes.
I received some messages from some of the residents that they did not receive the email, so
Okay,
I'm
they
not
need
sure
to
who.
contact. They need to contact Iman. Make sure that she submit all the names according to our roster from the Saudi Council. That we have 54 candidate resident, and and they have sent the email to each one of you. There is some potential that you may have received the email into the junk mail, or it may have been blocked for one reason or another. So check your other email, or check from another computer using another internet network. And if all that fails, communicate with the secretary, Iman, and she will hopefully she will at least take some more information from you to pass it on to the organizers of this program. Once we open this, it should be open for about a month, for the whole month of February. You can log off and log on again and again and again, and save every time. So we expect you to finish this. It's about 100 questions. We expect you to finish it within 2 weeks, maximum 3 weeks. There's education material for each question, very similar to the CSAT, but it's also only looking at the or concentrating on the areas of the universal topics. Any other questions? Okay, we'll proceed. So I'm going to sign in. And again, I tell you guys, I'm not really very familiar with this program, and I expect you the same, but we will work through it as we go. Okay, so I go in here and it says assessment department, mock and promotion exams. For me, they have shown me those arrangements. Earlier on, I could see cardiac question 1, 2, and 3. So they put 3 questions for me as an example. Now I don't see them, so I may not be able to tell you the whole story about this, but I'm going to go through the assessment department and see if I see anything familiar there. Again, it's as new for me as it is for you guys, so let's work it out slowly. Okay. All right, so we have assessment, cardiac surgery assessment. 100 questions in the first one. It could be this one. You could be all seeing the same thing. I'm not sure. Anybody has this open, this program open?
I opened, Doctor. I tried before. They are telling that nothing here, not yet. So come back again. This is what's
Okay.
telling.
It's supposed to have been opened, timed to 1 o'clock Saudi Arabia Kingdom time. So Mecca time is 1 o'clock. So it should be just open about 5 minutes ago. And that's why I asked each one of you, whoever have access, to go ahead and open it and be with us. Can somebody else see if they can open their program?
I opened my account, Dr. Farid, but I don't see the same page as you have.
Yes,
I do have
you will only see the subject matter, which is the questions for the subject matter, universal topics for 100 questions.
What I do see is a cardiac surgery assessment. It is
so the same as number 1 I have here, cardiac surgery assessment.
I think so, but it's not like this. It's like a box showing a cardiac surgery assessment, and the time interval for this assessment is 4 weeks.
Yes, so that's basically what it shows. Mine is experimental, so I don't know really what I'm gonna see next, and I'm gonna go ahead and try to open mine, but go ahead, each one of you have access. Go ahead and open your cardiac surgery assessment.
It's showing now, even for me.
Yes, so it was open 5 minutes ago for everybody, and it's gonna be open for 4 weeks for the whole month of February. You should be able to answer most of those questions, but the idea here is to answer the question, learn from the explanation for the answer, and then go back if you have to and answer the question, or they may give you a different question. It's just like similar to the CSAT, but it's automated. Okay, so I'm gonna go now and open mine and see what happens. الله يستر. هنفضح لكم الأسئلة كلها هنا. ها. Okay, nothing happened in my end here, so maybe I don't have access to the exam. Let's see, maybe test. Okay. Yeah. All right. So I'm not sure if you're all seeing the same thing as I am.
Welcome to the Adaptive Learning Introduction.
Yes, Doctor.
This adaptive learning module is provided by the Saudi Commission for Health Specialties in Area 9 Lyceum.
Okay, so it's an introduction. Basically, it talks about the exam, how is it going to be conducted. It says next, so I'm going to go for next and see what happens.
To help you learn as quickly as possible, this course will adapt to your existing knowledge and confidence levels. Using intelligent software, we will support your learning by asking questions and only show you the learning material when you need it. Before you start, think about how familiar you are with this topic and adjust the self-assessment slider shown here. Novice means that we will explain first before asking you questions. Expert means you receive less help, but if you know the material, you will move through the course more quickly. Regardless of the setting, the course will adjust to your needs. Once you begin, we will ask you to rate how confident you are in your answers. Be honest and don't worry about not knowing or being unsure about something. We use this information to optimize your path to proficiency.
So at the end, there will be no marks that goes into your records. The marks here are only to help you, to show you where is your weaknesses, okay? And if you're not sure, that's also an area of weakness. It will be worse, of course, if you say, I'm sure, and you get the answer wrong. Then that's a dangerous situation, because you could make big mistakes in the future. If you're, to be honest to yourself, if you're not sure, just say, I'm not sure, and go and read about the topic and then answer it again. If you are sure again or not sure still, you can mention that. This will help us design the question better for you so you can learn better. Let's say after the explanation, you're still not sure, which means that the explanation is not clear and it has to be clarified at a different level. Okay, does that make sense, guys?
Yes, Doctor.
Okay, anybody else have a different opinion or a question so far? Okay, I'm not sure really how to go into the package and the questions from here. So because those
السلام عليكم
questions.
دكتور، ماشي أنا معكم. أتوقع لو ضغطت next.
اوكي ما عاد في عندي next، انا خلاص غلقتها كلها.
اللي تحت اللي بالأزرق.
All right, here we go.
Here is a summary of what you will learn in this module.
دكتورة ثريا شكرا لنقذت الموقف.
لا لا عادي تقدر.
Okay, so this is a module introduction. We're going to go through it and see.
Before you start, think about how confident you are with this content, and adjust this self-assessment slider by dragging it to the right position. Novice means that we will explain first before asking you questions. Expert means you receive less help, but if you know the material, you will move through the course more quickly. This will help to set your optimal learning path, and you can readjust it anytime.
Okay, for this, I suggest every one of us is a novice, so which means like we are really inexpert with this. It may be better to put it at the lowest possible And then as you go through, maybe after the first week, you really feel good about it and you feel that you're getting along nicely with the program and the questions and the answers, you can probably increase the grade a little bit. Next. So this is the first question that we'll be seeing. I think there is a button here in the corner which says autoplay on with some sound if you want it to read. I'm not sure if that works, but let's say you're tired of reading, it can read for you. I'm going to try it and see how it works. So it's not really reading for me. Anyway,
جرب دكتور البلاي اللي فوق اللي مكتوب push allowed، لا اللي فوقها اللي مكتوب push reading.
ايوه ضغطت على الاثنين، عليها الاثنين. فايش يمكن يصير الواحد يعني to me the screen is too small to see anything here. You either have to use maybe a larger screen. I'm using my tablet, so or you may have to use a magnifier. It says here zoom in the bottom, zoom to fit ولا plus ولا كده. So I'm going to increase it and see what happens. Okay. All right, so we can do something like this and then try to move it. Can't move it this way. Let's see, maybe here. Okay, and then sideways if we can move it. That's the maximum it goes. Okay, so now I can read it. A 25-year-old woman had successfully repaired of complete AV canal defect and insertion of an epicardial pacemaker, which is usual as a child. So she had the surgery maybe 25 years back. Yesterday, she underwent reduced stenotomy for repair of the right AV valve, regurgitation, and pacemaker generator change, which is not unusual to see for those patients. She was extubated a few hours after surgery. The morning post-op day 1, her chest tube output remained bloody and her INR was 1.4. So it's a little bit concerning here, usually not much, but anyway. She was transfused 2 units of, oops. Can you all see my screen? And,
yes, Doctor.
And I see difficulty here seeing.
دكتور لأنك أنت you're taking it as a learning mode، يعني المفروض يظهر عندهم غير بس تتأكد من عندهم لأنه أنت we're doing it as a demo.
Yeah, that's okay. Yeah, I will go. Each one of them has their own program open, but I will keep it like this until I go to the answers, so to show them a couple of points there. But I want to see if I can see the whole thing. Let's see here. Maybe it. Okay, I'll keep it there. Or maybe when somebody can read it, well, maybe they're seeing something different, not like mine.
أنت دكتور عامل عليها زوم مرة فعشان كذا الكلام كله صار تحت. أو try to.
أنتوا شايفينها أنتوا do you see what I see؟
مش كل الكيس نصها بس زي الكلام اللي
نفس الشيء يعني حتى نفس الشيء. But this is the maximum it goes apparently. Anyway, 2 hours later خلينا نشوف.
دكتور سوي زوم اوت. لأن أنت you're not seeing it as their screens لأنه إحنا ما هذا كان الدمو حقنا بس. أيوة فأنت في this demo حتضطر تشوفها كذا smaller and you scroll down. غير الريفيو فيز.
يعني هم المفروض حظكم أنتوا أحسن من حظي.
unless إنه أحد من أنا one of the residents share their screen and then they show them, that's something else.
Okay. All right, so we'll go with this. Can you read the? Can you see the letters there? I'll continue to read if you.
You wanted me to read it, Doctor?
Yeah, go ahead, please.
Okay, so she was extubated a few hours after surgery. This morning, post-op day 1, her chest tube output remained bloody and INR was 1.4. She was transfused 2 units of fresh frozen plasma. 2 hours later, she developed progressive respiratory distress and required intubation. Current vital signs include temperature of 37, heart rate 110 per minute, and blood pressure 105/70. Her saturation is 97 on FI2 of 0.5, PEEP of 7, and appropriate minute ventilation with a tidal volume of 5 milli per kg. Pink frothy secretions are seen within the endotracheal tube. Her examination is unremarkable. The portable chest radiograph is shown in the image, and the echo was ordered. Brain PNP levels are normal. Which of the following is the most likely etiology?
Okay, so before we go into the details, let's go into the clinical side of it and ask one of the residents to take care to answer those. How do you think about this question? What are the things that most significant as you see it in this patient? Can you answer that, Ayat, as you are with me reading the question?
Yeah, it's saying here that she's tachycardiac and she's requiring more.
So mention one thing that's most important.
The frothy secretions within the endotracheal tube.
Exactly. So as a cardiac surgeon, once you hear pink frothy secretion, you really think about something major happening. And what's the usual thing that can cause this?
I thought about pulmonary edema.
Exactly. It's pulmonary edema unless proven otherwise. But here's something else. Additional information was given to you that the echo was ordered. So we're looking for other reasons. But the PNB level is normal. Which, yes. How does that relate to pulmonary edema? What are the usual level of PNB with pulmonary edema?
I'm not sure about the level.
So that's the level of the question that's related to. So this patient is having a major problem with lung issues, and the PNB is normal, so it's not pulmonary edema. It cannot be pulmonary edema. It must be something else. If it's something else, what else could it be?
Related to transfusion.
Exactly. So that's how the construct of the question is making you thinking, in addition to the image that you've seen. Now, okay. I'm not sure how to go to next. Okay. Yeah, I give you the choices. So can you read the choices and pick up one of them?
So etiology might be PE, right ventricular failure, delayed protamine reaction, or transfusion-related acute lung injury. So I'm going to choose TRALI, transfusion-related.
Wonderful. Why it's not pulmonary embolism?
Doesn't look like any with this scenario.
Why?
The chest X-ray, the frothy secretions.
What do you expect in the chest X-ray and massive pulmonary embolism?
The pulmonary vasculature will be the lung field, will be black, and the pulmonary vasculature will be decreased.
Okay, so it's opposite to this picture totally.
Yes.
Right heart failure usually affect the liver and the kidney rather than the lungs. It's usually left heart failure, and the valve they operate on is the right side, right AV valve rather than the left AV valve. All these things goes against that, and delayed protamine reaction or even acute protamine reaction is also part of the list. It could be something like this, but then we expect it to be the type of pulmonary edema response. Anyway, so you're choosing this answer, and I'm going to mark it now. Okay. And then, are you sure about the answer, Ayat?
Yes, I am.
100% or not 100%? Do you think you know the answer? Or you think, do you know the answer? You think you know it? It's not sure, but that's what I guess, or no idea whatsoever. I just picked it up.
I know it. I would choose I know it.
Okay. All right. Okay. So I did mark it as such, and yes, you got it, and there's the answer here. It's better for you guys to read those answers, huh? It's only one page of something. It gives you good references about different things, and it talks about the details of pathophysiology or the inclination of doing certain testing. This is the material that we expect you to know. And the next question on this topic may come from any area around this, from the same question, from the same answer. So you may be asked about the same question, but a different area here in the answer sheet, okay? Knowing this will mean that you are mastering this point in knowledge that we expect you to do, okay? All right, so now I'm not sure how this goes. Says next. Okay, challenges. Let's say, Ayat, you really didn't feel good about this question. It's a bad question. You think it's too hard for us, or you think there's a mistake in the spelling, or there's something major mistake in clinical judgment, like the question we saw yesterday or this morning, I can't remember, when somebody was saying, well, clinically, I wouldn't go this way. He gave me those choices, but there's a better choice. There is a better way of dealing with this patient. Then click on challenge, okay, and put your comment here. This answer is not appropriate, or this question is not appropriate because it's too hard. It's out of my league. It's out of the universal topics, for example. Or there's a mistake here, clinical mistake, or there's a typo mistake somewhere, okay? You don't have to put this for every question. We expect maybe you'll be able to do this comment maybe in about 10, 15, 20%. Is that acceptable, Thuraya?
عفوا دكتور ايش اللي acceptable؟
So I was telling them about the challenge part.
ايوه انا سمعت
and how
بس
can they
20%
respond to it.
Yeah.
And the area to respond is one of 2 or 3 things. One of them is that it's totally inappropriate question, or there may be a mistake in clinical scenario, or judgment, or typo mistake. They can report for us.
Yes, yeah. فهو level, difficulty level زي ما قلت إذا كان في any flaws سواء كانت grammatical ولا ممكن يعني duplication or something of information, or the key ممكن يكون wrong. Maybe we labeled the key incorrect by accident. يعني هذه من flaws. Or زي ما قلت اللي هو clinical judgment يكون في شيء مثلا has 2 answers because different hospitals, it's like protocol driven. Maybe this hospital does this thing and the other hospital does that thing. عشان مو متوفر عندهم like certain يعني tools or certain like machines. You can challenge us at that time عشان a lot of people who write the items write على the best practices or اللي موجود في الكتاب, while in real life أنتوا تكونوا تطبقوا something else, تطبقوا شيء ثاني. So you challenge us on that عشان we open it like to have 2 answers or we change the answers and so on.
Okay, so we can improve those questions next time and third time. And remember, this is a learning experience, not only for you, but also for us. Okay, well, with this, I think we can conclude, submit here or cancel, and then we go to the next, and it should show the next questions. Does anybody of you have any questions? We're going to conclude here in 1 minute. Does any of you have any questions related to the formative assessment exam?
Yes, Dr. Farid.
تفضل لؤي.
So how are you going to utilize the data out of these answers? Are you going to modify the curriculum upon there's any deficiency in the knowledge more?
Okay, it's a very good question. And that's why we have highly qualified expert people like Dr. Thuraya being with us from the start. We are contemplating changing the curriculum to what we call EPA, which will be entrusted professional activities, which means that we are looking at certain skills, including part of the knowledge that relate to this for each level of your training. And we'd like you to learn as you go and not to wait until the end of the year so you can have 1 exam. Those exams will be, those assessment will help you decide which area you need further education or further learning. Let's say we all find that all the residents are weak in 1 area, which is important. Then we have to talk to all the program directors about changing something there, or providing more lectures or interactive session with video, etc. on that particular area. We may find a subset of group, so it can be kind of tailored to different groups, maybe first-year resident, second-year resident, 7-year resident, and so on and so forth. So it's a very helpful tool for us to help you learn better. That's the message I get. Thuraya, can you please give us your comment on this?
يعني هي الانتنشن اللي نبغى نسويه يعني زي ما قلت الدكتور يعني if we highlight areas إذا في gap in knowledge يعني احتمال إنه مثلا في بعض التخصصات there are questions that are في المنهج بس it's not taught and we can't highlight it but this will help us highlight لأنه ممكن يكون to a specific program or hospital so we can try to address that so we can know where the problem is so that will help us in that area. The other thing, it will help us feel, if let's say you feel that this should be taught and it's not taught, so it will help adjust the curriculum. In the future, if it's going to be EPA when we move, يعني لما هو الدكتور يقول EPA مو بكرة حيتغير هذا المسألة يأخذ يعني وقت يعني a couple of years. But the idea it will help us يعني know what is important and what's not when we do that. And the other thing is من ناحيتكم أنتم, so let's say يعني all of you are having the same question نفس الترتيب. But if one of you gets it wrong or says I don't know or something, وقتها the pace of the questions is going to differ. So my question, let's say 5, and your question 5 might differ because I answered something incorrectly. So it's going to skip and come back to you later. You're going to have, each one's going to have then their own learning path. And then you get that information so you can know which question مثلا علقت فيه أكثر من مرة or which areas weaknesses. إحنا مبدئيا we just started it simple but with time when we categorize it according to a blueprint or according to let's say treatment or management or إذا كانت مثلا endocrinology, cardiology like that, the subspecialties acute and chronic, you will know which area you're deficient in or you have more weakness and which one you're good at so you can مو لازم تركز عليه or تركز مثلا again let's say you put your effort somewhere else. And the other thing we use data is for and طبعا this helps supervisors to help you in that area. So if you're with a situation where they know that you have a weaknesses in this area, you can ask for that help and then they can also tailor it for you knowing your data. The other thing is for the item itself. So if we collect a data, item analysis for the item, it will help us see if there's a problem in the item, if it's discriminating between the students, if it's fair or unfair to fix the questions. So this one also help us يعني حتى data when we have more exams or summative exams, it will help us يعني be informed more. Maybe if that answers the question.
Yeah, one more something to add to this is that we also would like to develop a sense of confidence in what you know. So in the beginning, you may not be able to answer all the questions with great confidence, but after this learning experience, you should be able to gain more and more confidence and become the know-it person. Let's say, I know I am answering this, I know the answer correct, no question about it, something like this. Okay, Luay, does that answer your concern?
Yes, Doctor, thank you.
Okay, anybody else have any questions or comments?
Just one question, Dr. Farid. If I started the question, should I complete the whole 100 question in one set, or I can just pause and come again later?
No, you're from Jeddah or from Mecca?
I'm from Mecca.
Okay, so it means that probably you can do some questions and then go روح الحرم وطف لك كم هذا وادعي ربك انها تكون صح وارجع اكمل الباقي بعدين.
It's open for 1 month, so you have 1 month to complete it. So it's the idea is it's not to do it on one day. The idea is to do it on your own pace and you learn from it. And you complete the 100 questions. طبعا في it might feel like more 105 or 106 لأنه the question will come back again after you read the information and you understand. It will come back later again to make sure إنك أنت فهمت. You say, okay, I got the concept, I قريت the information, and then it comes back to you and then you answer it correctly.
يعني مو لازم تكملها كلها في نفس one session, لا. You can save it, I think, at the end. I'm not sure how can I...
I think it's automatically saved. Then you can see up on the top, it's progress. It tells you like you're 2%. Once you log in again, it's supposed to continue from that.
Okay, how to log off, like here?
أنا عندي ما كان logging off لأن كان أنا reviewer. بس I think if you click FK إذا ما طلعت لك, or if not, I think if you just close it. I'll have to make sure about that. بس in our mode هنا ما يطلع لنا logging off. أنا ماني عارف كيف يطلع learners mode لأنه I couldn't access the learners mode.
فعلا أنا ما عندي أبدا هنا.
أيوة إحنا عندنا ما عندنا. It's either if they click their name on top حيطلع log out. The other thing, أنا when I tried it on the computer, when I just closed the tab and I came back to it again, it continued from where it was. فمبدئيا if any one of you from the beginning answers a question 2%, let's say, or 1%, يعني بس جاوبت السؤال and you logged off or you closed it and you came back again, it started from 0, it's good for us to know and just to make sure, and if we miss something in this area, عشان ما يعني from the beginning just check how to log in and log off من عندكم if it resets من the beginning or it continues عشان we just fix it from our side if we missed it.
جميل. Okay, so Mohammed, was that answering your concern?
Yes, thank you, Dr. Farid and Dr. Thari.
Okay, anybody else have any questions or comments? Okay, wonderful. So Luay, we will finish this part of your afternoon activity. I thank you, Dr. Thuraya, for being with us and helping in this regard. You saved the day again and again.
لا يعطيك I'm here to help يعني.
And if there's any concerns, some people, I'm not sure if you've been here from the beginning, some residents said that they have not received the link or the password.
طيب, so I will طيب I will can you الدكتور تبغى تجمع لي ايميلهم وترسل لي اياه or how do you want it to work or do you want me to
طيب I gave
يعني
your contact I gave your contact to Dr. Luay Al Khalaf.
Okay, yeah.
Please, for each one of you who have not received the email or have not received the password, pass your name and email to Dr. Luay.
And he can send it to me.
And he will forward it to Dr. Thuraya this weekend to be taken care of.
Yeah, and then I can confirm with you and Dr. Luay then that we added them or we checked. Just in case, check the spam or هذا because again, it could be that some institutions, if they use their institution's email, then it could be that sometimes the institution blocks it for some reason. It's like there's a firewall, so it's better to use your personal email. For just make sure also from your side, and I'll check with the people and them.
Yeah, I gave him different alternatives in the beginning when I answered this, but I'm glad that you concur with most of it. Thank you very much, Thuraya.
Okay,
thank you, Shabab. You all have a good luck, and we are there to help you at any time. Yalla, مع السلامة.
Yeah, شكرا, مع السلامة.
Now you can take over.
Dr. Farid and Dr. Thuraya, thank you very much. So as Dr. Farid, please, for anyone who did not receive the email, just send me your email so I can forward it to Dr. Thuraya. Dr. Rasha, are you ready?
Assalamu alaikum. Yes, I'm ready.
Yes. Can prepare the slides. I'm not sure that I can see Dr. Rashid. I will just call him and get back to you. Just prepare the slides so we can start.
Okay.
I can stick around if you need me.
He called me already, but he said he had some issue logging in. I'll just call him.
I'm around anyway, so
sure.
Whatever.
Thank you. Dr. Rasha?
Yes.
Yeah, Dr. Muhammad is not answering, so I believe we can start and then maybe he will join us later.
Okay.
Thank you.
طيب, Assalamu alaikum. Today we're going to talk about the mitral valve repair after we have finished the pathophysiology and the functional mitral regurg previous week. I'll try to make it as simple as I can. It is one of the complex topic that you will face when reading. So we're going to talk about a surgical anatomy overview in one slide, and then the repair technique for the maximatis mitral valve, timing for surgery, repair with replacement, predicting valve complexity, operative philosophy, operative exposure, repair strategy, different surgical techniques for posterior and anterior leaflets, special consideration that we can face in the OR, and rheumatic mitral valve repair. So this is a case presentation that we have done 2 weeks earlier. 58 years old, male patient, not diabetic, not hypertensive, non-smoker, referred for mitral regurg. He is fairly active with NIHA class 3 symptoms. Focus exam shows holosystolic murmur at the apex. ECG was unremarkable. Chest X-ray, they have a mild cardiomegaly. Ejection, echo showed ejection fraction 60%. Severe mitral regurg, flail posterior leaflet, severe pulmonary hypertension with LV diameter 3.5. Coronary artery was normal, labs were normal. So from this case presentation and from the previous lecture, we took note that this is a class 2A, 2A indication for the mitral repair because the patient has a NIHA class 3 symptoms and he has a good ejection fraction. Okay. So this is the Echocollapse of our patients. As you can see here, this is a long axis parasternal axis view of the echo. This is the left atrium, this is the left ventricle, this is the aorta, this is the atrium. Now you can see here, this is the mitral valve with a severe mitral regurg. So just to tell you one thing, for the juniors, we have this mosaic color means that we have mitral regurg. If it is one color, blue or red, so red is away from the probe and blue is going through the probe. So mosaic color means that we have a mitral regurg, and if you have a large mosaic color like here, this is a severe mitral regurg. Okay, so a quick surgical anatomical review. We all know that the mitral valve has a 5 discrete component, which is the annulus, leaflet, the papillary muscle, the chordae, and the LV. So the annulus is a myocardial connective tissue area where the mitral leaflet are attached. It's surrounded with an important structure laterally surrounded by the LCX, medially coronary sinus, superiorly the aortic road, superior-medially is the AV node. Posterior annulus is usually involved in the maximatis disease. Left and right fibrous trigon are usually related to the anterior annulus and are contiguous with the aortic valve cretin and must be identified during surgery. So for the leaflet, we have anterior and posterior leaflet, of course, and the anterior leaflet is the largest one with a continuity with the left and non-coronary cusp of the AV of the aortic valve and is located directly beneath the left ventricular outflow tract. The posterior leaflet is crescent in shape and is more commonly involved in the degenerative disease, not in rheumatic disease. For the papillary muscles, we have anterior and posterior medial. Anterior lateral receive blood from both LAD and LCX. Posterior medial usually receive blood from the PDA or a branch from LCX. That's why it is more susceptible to infarction and rupture than the anterior lateral one. For the chordae, we have 3 sets, primary, secondary, and tertiary. It's important to identify the chordae during the OR because you know what chordae you will resect and what you will preserve. Primary chordae usually we should preserve in the OR. So primary chordae are those that attach to the edge of the leaflet, secondary that attach to the underside of the leaflet. Tertiary chord, which is usually found in the posterior leaflet, attached to the undersurface of the leaflet directly from directly from the ventricular wall instead of the papillary muscle. The LV plays, of course, important role in the mitral valve anatomy. It acts as a concert with the papillary muscles via the chordae to pull the leaflet edges during systole, thereby maintaining the line of the coaptation. If you have an LV dilation for any kind of etiology, failure of the central coaptation will happen and regurgitation is created. So such type of regurg that we already discussed previously is called a functional regurg, normal leaflet with dilated annulus. This was a brief review for the anatomy. Then we will talk about different kind of repair mathematics or rheumatic. Yes?
Yeah, I just want to welcome Dr. Muhammad Rashidan, who just joined us. Thank you, Dr. Muhammad, for joining us for today.
Okay.
You can proceed, thank you.
So for the mitral valve repair, we have techniques for myxomatous repair, and we have a technique for rheumatic. We'll start with the myxomatous mitral valve disease. Of course, you all know that it's a fibroelastic it's a defect in the fibroelastic connective tissue of the valvular leaflet, chordae, and annulus. This defect will lead to abnormal elongation of the valve tissue and chordae. So each abnormality in the valve will give you its regurgitation in its own particular manner. So if you have an annular dilatation, which is usually in the posterior annulus, there will be a separation in the middle of the valve between the two leaflets. If we got a leaflet redundancy, then the movement of the redundant leaflet in the left atrium during the diastole will be the main cause of the regurg. If we had elongation of the chordae, which is mainly due to which will cause leaflet tissue to move also in the left atrium during diastole and result in compromised coaptation. If we have a ruptured or flail leaflet, which is usually a result from a systolic stresses, fracturing the weakened chordae and causing a severe regurg. So each one of these abnormality can happen with the myxomatous mitral valve disease. For a quick pathophysiology, mitral regurg is a pure volume overload of the LV, and it's called a vicious cycle where the excess volume overload by time result in a ventricular failure. And this ventricular failure will lead to annular dilatation, and this will result in greater degree of MR. So MR created by the left ventricular failure primarily occur with ventricular dilatation. So what are the anatomical surgery? Already been discussed in the previous lecture. Just to remind you, when you have a patient with a severe MR, asymptomatic with preserved LV function, and the repair is successful, or likelihood successful of the repair is more than 95%, then the repair is recommended. Keep in mind that under anesthesia, the loading conditions are not physiological, and the mitral regurg is underestimated. So sometimes you need to give some to increase the afterload to correctly assess the mitral valve regurg. So to give you just a few scenarios that you will face during the cases you face. So if you have a severe MR with moderate ejection fraction, repair is recommended because the ventricle already exhibited signs of decompensation with a low degree of MR. So if we leave the MR by time, it will cause severe decompensation and LV dysfunction can occur. MR with aortic stenosis, usually we don't repair the mitral regurg if the valve is structurally normal. Of course, if you have abnormal valve, you need to repair it. But if the valve is structurally normal with aortic stenosis, usually we don't repair because here the mechanism of the MR is functional as it's exacerbated by the aortic stenosis and the volume overload. And when we correct this aortic stenosis with the euvolemia, this will reduce the MR. Severe MR with cabbage and the myxomatous mitral valve, not ischemic, repair is recommended because the patient who will do a cabbage, this will not impact on the pathophysiology of the mechanism of the MR in this case. MR with low ejection fraction, repair of course is recommended, but if the patient exhibits symptoms of heart failure before the surgery, then optimal diuresis should be undertaken before operation. So repair versus replacement, it's known that compared to mitral valve replacement, mitral valve repair is associated with greater freedom or lesser degree from operative mortality, structural valve deterioration, reoperation, infective endocarditis, thromboembolism, and hemorrhage. For the subvalvular apparatus, as much as you preserve the subvalvular apparatus, mitral valve repair is better in maintaining left ventricular geometry, and of course, this will affect the left ventricular function and will cause less left ventricular dysfunction compared to mitral valve replacement. So predicting repair complexity preoperatively with the echo, when you see the echo, you know that this is going to be a simple repair or a complex repair by few steps. So lesion associated with straightforward repair is a type 2 isolated P2 from degenerative disease, which is our case today, and type 3 from the ischemic disease. Lesions that are associated with the more complex repair when you have a bileaflet prolapse like in Barlow disease, which we will discuss just in a few moments. Type 3A lesion from rheumatic disease, lesion with infective endocarditis and leaflet perforation, cleft mitral leaflet, primary SAM, and previous mitral valve repair failure. This will give you an idea that you will have a complex repair of the mitral valve. So back to our case, this is the echo. We will just go systemic analysis of the mitral valve. طيب زي ما قلنا, this is a long axis long axis view. To assess the valve, you need to assess the leaflet, the annulus, the subvalvular apparatus, and of course the LV function. So for the leaflet, you need to know the thickness of the valve, mobility, calcification. So for the thickness, we can measure this. The normally is less than 5 millimeter. This is looks like 0.4 millimeter. So this is, we have a normal thickness of the valve. The mobility. Okay, so you can see the leaflet is freely mobile with drop leaflet of the posterior leaflet. This is the posterior leaflet. You can see the drop in the posterior leaflet into the LA, which causes an anterior jet. Then we look for calcification. Of course, there is no calcification in the leaflet. The calcification will appear like a white dots on the leaflets. And then for the subvalvular apparatus, you can see that there is, it's better to see it with the long axis view. There is no calcification or redundancy. Okay, from another view, we can see, okay, this is a short axis view of the valve showing the redundancy of the posterior leaflet with no coaptation line between the two leaflets. This is the anterior leaflet, and this is the posterior leaflet. Okay, you can see here the color Doppler showing a severe mitral regurg with no coaptation line between the two leaflets. So after analyzing the leaflet and the subvalvular apparatus, you should look for the annulus. But before that, I want to show you the 4-chamber view. This is so this is the 4-chamber view showing clearly no coaptation line between the anterior and the posterior leaflet. This is with the color Doppler view. You can see here no coaptation line between the anterior and the. Yes.
Excuse me. This is Dr. Rashidan speaking.
Okay, doctor.
I can ask you a question, please, about this echo. Can you please elaborate more on the mechanism of MR, why this patient have MR, and what are the direction of the jet, and how we quantify MR with echo, please?
Explain that previously. Okay, let's explain now. But in the different view, doctor, or you want in this view, I have another views.
Whatever you like, just for clarification, please.
So I will start with the short axis view. As you can see here, this is the anterior leaflet of the mitral valve, and this is the posterior leaflet. This is the P1, this is the P3. You can see the prolapse segment with the P2 leaflet that cause the posterior leaflet into the left atrium right here. Yeah, you can see this is the posterior leaflet here. It's dropped into the left atrium that due to prolapse segment of the P2 that cause no coaptation line between the two segments. I think I have clearer view than this. Wait a moment. Yeah, you can see the dropped leaflet of the posterior leaflet into the left atrium, you know. Okay, so you can see there is no coaptation line between the two leaflet because the posterior leaflet is dropped into the left atrium due to degenerative valve disease. Wait, okay, so this is a two-chamber view. Wait. So this is the anterior leaflet, this is the posterior leaflet. You can see there is no coaptation line, and this is the severe regurgitation. This picture just to show you that sometimes when the severity is not clear, we can do some sophisticated measure like the regurgitant jet area and the vena contracta. And here we can measure the vena contracta. When it's more than 0.7, then it's a severe regurg. So after that, we need to, after analyzing the valve, the leaflets, and the subvalvular apparatus, you need to measure the annulus. As you can see here, the annulus is dilated with, and also the LV function, which is good in the two-chamber view. And so to assess the LV function, of course, it's by two mechanisms: the inward movement of the wall during systole and the thickening of the wall during contraction. And you can see here we have a 60% ejection fraction.
So as you said, this is primarily posterior leaflet prolapse or flail, right?
Yes.
So what are the difference between posterior leaflet flail and posterior leaflet prolapse? And does it make a difference?
Posterior leaflet, posterior leaflet, and posterior leaflet prolapse.
Yeah.
I think I don't know what is the difference, but I think the posterior leaflet prolapse will go to the left atrium, and the flail posterior leaflet. No, I don't know.
They both gonna go to the left atrium.
Yes, to the left atrium. So what are
when you have flail,
the prolapse will be dooming of the posterior leaflet? Or
prolapse, you still have attachment of the leaflet because the chordae is elongated, but it's not ruptured. Usually flail when there is no attachment for the leaflet. In this case,
okay.
There is, I think it's combined, but it's mainly flail because you could see that the whole posterior leaflet, it is go back to the left atrium, and you can tell that the jet of this mitral regurg is where you think the jet. What are the direction of this jet?
To the anterior leaflet.
Is it anterior directed jet? Yes, because it's going from the posterior.
Yes.
So, and also when you look at the echo, because look, when you embark on mitral valve repair, the most important thing you need to understand the mechanism of MR before you go to the operating room, you know?
Yes.
So when you look at the echo, you need to know, and when you look at the TE especially, you need to analyze the areas of A1B1, A2B2, A3B3, you know?
I have a picture for TE.
Okay, go ahead, Yalla, show me the TE, please.
Okay, but it's just a little bit late after I go further with the operative steps, okay?
Sure. And when you mention about the mitral valve repair, I'm sorry because I missed part of the lecture. Did you speak about the spectrum of the myxomatous mitral disease?
Spectrum, I just briefly know, يعني ما دخل details.
Okay, because now 90% of the mitral valve repair, we repair the valve in myxomatous disease, right?
Yes.
So you really need to mention this because that's where the complexity of mitral valve play a role, okay? Because the myxomatous mitral disease can go from a very simple B2 prolapse to all the way up to Barlow disease, okay? And each entity has its own techniques of repair and configuration. But I just want to mention this because I saw you mention rheumatic mitral valve repair.
Yeah, rheumatic will be late in the presentation. I will talk in details with the different types of repair in the myxomatous mitral valve.
Okay, thank you.
Okay. So for the operative strategy, first you need to expose the valve wall through complete development of sand groove, division of pericardial attachment of the superior and inferior vena cava, release of the pericardial retraction stitches, assess the valve through saline injection, and correlate with the intraoperative finding of TEE. and then perform the basic obvious leaflet repair, for example, a quadrangular resection to the posterior leaflet. Then implant an annuloplasty ring sized by the height of the anterior leaflet, not the commissure, because it sometimes will lead to downsize of the annulus. Test the repair and perform additional operative procedure as needed, if, like for example, if you have a left closure. So set up its sternotomy or minimal invasive. For the plegia, it's for the bypass, aortobicaval bypass. For the plegia antegrade or plus minus retrograde, the LV is vented directly through the mitral valve. Carbon dioxide infusion is used to minimize the intracardiac air. And TE is important, of course, for de-airing and assess the potential of the systolic anterior motion of the anterior leaflet. This is the TEE. So as you can see here, this is the posterior leaflet. This is a prolapse leaflet, صح دكتور? From the TEE, and this is the anterior dooming. This dooming is characteristic for a prolapse posterior leaflet.
Well, I think it's not 100% clear, but yes. Okay, stop here. What do you think? Which part of the mitral valve is this?
Which part of the mitral valve?
Is it A2, B2? It's A3, B3. It's A1,
this
B1.
Is no P2 usually in the TE, and most obvious P2 and A2.
Exactly. When you see this, when you see the aortic valve in the picture, we call it like the 3-chamber view. This is when you see the A2, B2. So this mainly think it's B2 prolapse. I don't know. From here, I can tell you it's B2, but you have to go further to show me the A1, the B2, B3, and B1. Okay.
I have the short axis view. So this is the dooming of the posterior leaflet. You can see here.
What we call this entity of the myxomatous mitral disease? When you see the whole posterior leaflet thickened and elongated.
Barlow?
It's not Barlow's. Barlow's is bileaflet, right?
Okay.
We call it formifrost.
Formifrost.
Formifrost. I can show you. I think I will see if I can later share with you some slides. I will show you some of this if we have time. Okay, go ahead. Keep going.
So this is the short axis view of the TEE, showing the anterior and the prolapse segment of the posterior leaflet, which is the P2 segment here. I hope it's clear here. This is the P2 segment of the posterior leaflet, and it's very clear here. Okay. So for the operative exposure, we have 4 operative exposure for the mitral valve. The standard left arteriotomy, which is at the center groove. Incision is made in the left atrium, anterior and medial to the right superior pulmonary vein, and continued inferiorly. The biatrial and transeptal incision is usually used when you have 2 valve pathology like tricuspid and mitral. So an oblique incision through the free wall of the right atrium and through the right atrial appendage down to the left atrium. To the left atrial lobe is joined with the second line through the intraatrial septum medial to the crista terminalis, from the Eustachian valve to the edge of the superior limbus. This is superior lobe incision I never seen before. So it's an incision made across the right atrial free wall and continued between the superior vena cava and the right atrial appendage. And the right anterior lateral thoracotomy is used for the minimally invasive redo surgery. And so for the valve analysis, intraoperatively, final decision can be made whether to repair is possible or the valve must be replaced. Look for the jet on the atrial wall to confirm the direction of the jet. As we said, anterior jet lesion means posterior leaflet prolapse or anterior leaflet restriction. Using 2 nerve hook of equal length, examine each element of the valve apparatus. We assess the annular for dilatation, and usually it's as roughly same surface area of the normal anterior leaflet. Then we examine the chordae, distinguishing between normal primary chordae, abnormal stretch or ruptured or fused chordae. Then using the commissure as fixed reference point, work systematically along each leaflet with the nerve hook to assess the location and the degree of the prolapse. Okay, so this is a video showing demonstrating how to correctly analyze the valve. So assessment of the annulus, usually start, assessment of the valve usually start with the annulus. It usually look like a D shape, as you can see here. And the trigone should be identified. The area between the trigone is usually fibrous and constant. The anterior leaflet is examined for any redundancy or prolapse. And then we examine the posterior leaflet. As you can see here, the posterior leaflet is large compared to P1 and P3. So to identify the prolapse, P1 is usually used as reference point and gently retracted, and other leaflet is used to compare. And as you can see here, we don't have prolapse of the other leaflet. Lastly, you should look for any abnormality in the subvalvular apparatus. So repair strategy, the steps you should keep in mind. So prosthetic ring or band is mandatory in all repair procedure. The best approach for the maximatis disease is to consider it functionally too small for the anterior leaflet. So we use an upsizing ring for the degenerative mitral disease to avoid occurrence of SAM. And also the height of the posterior leaflet should be 1 to 1.5 centimeter to prevent SAM. The reconstructed posterior leaflet should appear like a smile. So the protocol is posterior leaflet repair, place the annuloplasty ring, assess for any anterior valve leaflet pathology, because usually the annular pathology will give a falsely appearance of the anterior leaflet pathology. So now we're going to go with the surgical techniques. Any other questions before I go to the surgical?
Can you go back to the previous slide, please?
This one?
Yeah.
Okay.
So, is it all necessary to put all the ring before you do your repair and the posterior leaflet?
It is what necessary for?
To put the ring before you do your repair?
No, of course.
But you said posterior leaflet repair, place annuloplasty ring after, then assess for anterior complex. Okay. Maybe I understand. Okay.
Okay.
So how would you repair a posterior leaflet? Are you coming to that?
Yes, I'm coming to that now.
Okay, before you go to that, you mentioned something about SAM, right?
Mm-hmm.
So
tell me what in details about it.
You're going on? Okay, sure.
Okay.
Fine. We'll wait. Okay, thank you.
Okay. So different surgical technique for anterior and posterior repair. For the posterior repair, we have mainly 4 techniques, and the most common technique is the quadrangular resection, because as we all know that the most common mitral valve pathology, almost 80% of it is the maximatis degenerative valve disease, which is usually caused rupture or elongated chordae. So the most common repair technique is the quadrangular or triangular resection of the posterior leaflet. So as you can see here, this is the prolapsed part, which is the P2 from the posterior leaflet. We resect that area, either triangular or quadrangular resection. Then another incision is made just adjacent to the resected P2 segment at the base of the annulus. For sliding valvoplasty. So the two parts of the leaflet, which is P3 and P1, is advanced together and reattached to the annulus from either side, and then the two free edge of the leaflet is approximated together And after that, after repairing of the leaflet, we do we put the band or the ring, and the side is usually taken by the anterior leaflet height. Okay. So this is an intro of picture showing the sliding repair of the posterior leaflet. So first inspect the valve and identify the prolapse segment and the primary chordae to preserve it and to determine the resection area. The entire prolapse segment is resected. And throughout the process, care is taken to preserve the normal primary chord on either side of the resection. Then a second incision is made along the base of the leaflet immediately adjacent to the annulus. Okay, from both sides, from here and from the other side also. Then the corner of the P3 segment is sutured into place laterally, sliding the P3 scallop toward the remnant of P2. This is a robotic technique, so they use interrupted technique and open running technique is used. Then the leaflet edge is reapproximated. As you can see here, this is the two leaflet edge. Finally, when reattaching the leaflet to the annulus, the depth of each part on the leaflet will determine the extent to which the height of the posterior leaflet will reduce, which should be less than 1.5 centimeter. Okay, after that, the ring is placed and the valve is tested. Okay, this is the final result. This is the posterior leaflet and this is the anterior leaflet. So there is another technique for the which will give you the same result of the sliding valvoplasty, but because detaching the leaflet from the annulus for it could be somewhat daunting. So this technique gives you the same result of the sliding valvoplasty without detaching the leaflet from the annulus. So this is the P2 segment. The prolapse P2 segment also we resected, and then we just advanced the two leaflet together without detaching the leaflet from the annulus. There we have, okay, this is intro. So you can see here it's the same previous step. Inspect the valve and identify the prolapse segment. After that, the entire prolapse segment should be resected. This is a triangular resection of the P2 segment. Okay. So without doing an extra incision in the annulus, the two edges of the leaflet is then approximated. This technique is minimally reduces the height of the posterior leaflet. Okay, so, okay, this is the repair of the both leaflet. So a ring is then a repair is completed with the posterior annuplast ring. Usually it's a flexible incomplete band starting from the medial trigon with the interrupted horizontal matrix suture. For degenerative disease, as we said previously, care must be taken not to over downsize the mitral annulus, which will increase the risk of the post-op SAM. Okay.
So, Doctora, the difference between the two is that we are not cutting from the annulus only?
Yes, yes, we are not detaching the remnant part of the leaflet from the annulus.
Okay.
And that's the technique we used for our case.
Can I ask you a question, please?
Yes.
So, what are the difference between quadrangular resection and triangular resection? And when we use triangular, when we use rectangular, and when we use the slidoplasty? What are the indication for each repair?
So for the sliding plasty, usually it's used when you have a hole, the posterior leaflet is prolapsed. But when you have a specific segment, like in our case, only P2 segment is prolapsed, then you use either triangular or quadrangular resection. When to use triangular or quadrangular, I think it depends on the surgeon. I don't know if there is specific indication for it.
Okay. So historically, people when they start doing the mitral valve repair, they used to do a lot of quadrangular resection because this is the way the teaching was. The problem with quadrangular resection, you leave a defect at the annulus, you know.
Mm-hmm.
So people either you have to do annular application, so you have to applicate the whole annulus and then and just connect the leaflet edge together, or you need to do a slidoplasty. So slidoplasty usually we reserve this for formifrost or for Barlow's when they have a lot of extensive tissues. But even though nowadays people did you hear about the concept of respect more than resect?
Yes.
So people now, I personally rarely do quadrangular resection. I mainly do triangular resection, and if still I have some prolapse, I could reinforce my repair with with the artificial cord. Or sometimes, if you want to prevent SAM because the leaflet height is tall, you could fold the whole leaflet into the ventricle, and like with a special technique. But quadrangular resection, it's a good technique. You still can use it, but you have to be careful, especially if you leave a big defect at the annulus size, because you either have to do a slidoplasty or the foldoplasty, or you have to applicate the annulus. This is one thing. The other thing is, especially when you work in elderly patients, sometimes the tissue are frail, you know. So I have seen very bad cases that when you try to applicate, you can cause bleeding or very bad complications as annular atrophy, AV dissociation, atrioventricular dissociation. I just want to mention this, and we'll keep comments while you're going. Thank you.
Okay.
Doctor, just one comment regarding the half ring or the complete ring. Is there any difference or any indication for each one?
That's a good question. I think it depends on the surgeon preference. This is one thing. The other thing is you have to understand that the area between the right and the left trigone, this is the fibrous body of the heart. So this area does not dilate. The area of the annulus dilate is the area between, which is mainly the posterior leaflet. Anterior leaflet attachment usually doesn't dilate. Look, in minimally invasive, most of the surgeons, they use the incomplete ring. Now, rigid or flexible, this depends on the primary pathology. Usually, we like to use a rigid because you want to stabilize the annulus. This is what mainly we use, like CG3 future ring, whatever. If you have a patient with Barlow's disease, you need to oversize a lot the ring because you need to because you have a lot of tissue and you want to prevent SAM. So these patients, they usually benefit from using a semi-rigid or flexible. I use the ring called ATS, Medtronic. But my advice to you, if you embark using this kind of ring, this ring comes fixed with its holder. Do not move the holder. Fix the ring first, or tie the stitches, then take out the holder, because sometimes you can change the shape of the ring because it's flexible or like semi-rigid. But using physio ring, like the complete ring, this sometimes used in the ischemic MRs because you need to decrease the epidiameter of the whole mitral valve. So if you're doing myxomatous, you can use complete or incomplete. There is no problem. If you do ischemic, I would advise you to use complete ring. If you to use flexible versus rigid. If you're doing a posterior leaflet pathology, you can use like a symbol. You can use a rigid. But if you're dealing with the Barlow's disease, when you have a lot of tissue, you need to oversize and use a little bit of flexible to prevent the sound. Thank you.
Thank you, Doctor.
Okay. So a specific problem we have is a Barlow syndrome. The problem in the Barlow syndrome is that the whole posterior leaflet is elongated. In this particular pathological situation, the classical technique, which is the sliding valvoplasty, is necessary. So the entire posterior leaflet on both sides of the resected area, including P1 and P3, must be incised of the annulus, and careful advancement of the valve is carried out. Beginning at each commissure with running for or proline. The height of the leaflet is lower to avoid corrosion of the SAM and provide good coaptation point of the anterior leaflet. Because some of this leaflet may be 3 or 4 centimeters, so you need to keep in mind that the posterior leaflet should be not more than 1.5 centimeter. If the height of the leaflet is not shortened significantly, SAM is highly likely. So one of the other pathologies we have for the posterior leaflet is the commissure prolapse, and the repair is very simple. Just we do a commissuroplasty. Simple horizontal matrix suture is placed in the ruptured commissure to eliminate any regurgitation without need for any further resection of the leaflet. This is a video showing the commissuroplasty. As you can see here, intrapid or running suture both are effective. Okay, the two commissure is sutures together. Okay. When performing a commissuroplasty, they found that the valve area can be reduced up to 1/3 without causing stenosis. And after that, the ring is placed and the valve is tested for regurg. So this is for the posterior leaflet prolapse. We have talked about the quadrangular resection, the commissuroplasty, the what else? The sliding valvoplasty. For the anterior leaflet prolapse, the main technique is the chordae. The main problem is within the chordae. So we have different techniques for that. First, the anterior pathology is associated with less successful repair than the posterior valve. Preservation of the anterior leaflet is important. Resection can be done, but only with a small area of triangular resection to reduce the large bulk of the anterior leaflet. Then we will deal with the chordae. Either we do reduction of the chordal height by implantation technique, or we can use artificial, which is the most common technique used. We can do chordae transfer. No one is using this technique now. And HCS technique is very successful when you have a high probability of SAM. So chordae shortening by implantation into the papillary muscle. The papillary muscle is incised, and the redundant tissue of the chordae is folded into it, and then just a running sutures to close the papillary muscles. Okay. This technique is not being used anymore because it shows that because additional chordae rupture may occur after use of this technique. So for the chordae transfer, also it's not being used these times. What's this? The posterior leaflet. This is the posterior leaflet. This is anterior leaflet. So we take one part or small part of the posterior leaflet with its chordae and transfer it to the anterior leaflet, and then we close the gap in the posterior leaflet and attach the part we took from the posterior leaflet to the anterior leaflet. This technique has been reported with the long-term result, but involve both leaflet intervention when only single leaflet pathologies exist. So edge-to-edge technique in which the anterior leaflet and posterior leaflet are sewn together. It's one of the techniques that used in SAM repair and in Barlow disease. The two leaflets are sewn together at the coaptation line, producing double orifices valve. It has another name. It's called also Alfieri stitch. It's used mainly when you have a truly redundant anterior leaflet. A position of the mid portion of the anterior leaflet to the mid portion of the posterior leaflet will prevent elevation of the anterior leaflet above the level of the posterior leaflet, and this will eliminate the mitral regurg. So this is preserved for the pathology that has a bileaflet prolapse, like a Barlow disease, or in patient with a high probability of the post-repair SAM. So it's prevent elevation of the anterior leaflet above the level of the posterior leaflet. It simplifies the repair of the true bileaflet prolapse, especially in patients with high probability of post-repair SAM. Each orifices should be at least 2 centimeters in diameter. If the orifices are less than 2 centimeters, then the technique should be abandoned. So the artificial cordy, which is the most common technique used for the anterior mitral leaflet pathology. The goal of performing repair while using the cordy is to eliminate any regurgitation while preserving both leaflet and keeping the mitral annular symmetry. So the critical part of this technique is to determine the degree to which the leaflet is lowered and how tightly the stitch is tied down. Okay, so the leaflet height in systole should be at the level of the cordy, should be at the level to which the cordy length is adjusted. So here is the techniques for the artificial cordy. So after identification of the prolapsed segment, the suture is first passed through the leaflet and then through the papillary muscle just below the fibrous tip. Care must be taken not to injury or to interrupt with the native cordy. The needle is then passed, brought back through the leaflet 1 centimeter from the first bite. Then the needle is passed through the edge of the leaflet twice in a running fashion until the two end line across approximation. Okay, the sizing of the anterior leaflet is accomplished by pulling the edge of the leaflet to the corresponding hinge point on the anterior annulus. Okay, the artificial cordy should be just long enough to reach this point. In most cases, the anterior leaflet can be repaired with 2 sets of cords. Usually, they leave the lateral cords until until they test the repair to allow for readjustment if needed. Finally, the repair is completed with ring annuloplasty. Okay. So this is the post-op TE for our case. We did a triangular resection without the valvoplasty. As you can see here, the good coaptation line between the anterior and posterior leaflet, no more mitral regurg. This is the short axis view. This is the anterior and this is the posterior leaflet. You can see the good coaptation line between them. Of course, we need to keep in mind that we did not did a mitral stenosis, so we need to measure the valve area and the mean gradient in the valve, which should be less than 5. So here is the gradient is 2, which is the normal. This is a 4-chamber view, also showing the good coaptation between the 2 leaflets. This is with color Doppler. As you can see, there is no regurg, and this is the band here. So, any question? Okay, so now we're going to special problem and consideration we can face during the OR. For we can sometimes have a calcified annulus, so the stitches will be more difficult to place and the risk of paravalvular leak is increased. We can do a partial or total removal of the calcified bar. Only amount of calcium should be removed that allow adequate stitch placement. Extensively calcified valve usually indicate valve replacement. So now we're going to talk in details about the systolic anterior motion of the mitral valve, which is a problem commonly faced post-op. It occurs when the tap of the anterior mitral leaflet is displayed anteriorly into the left ventricle of outflow tract. This will result in a Venturi effect, pulling the mitral valve fleeting toward the left ventricle outflow tract and causing severe MR and left ventricle outflow obstruction. In comparison, during diastole, the left ventricle outflow will be normal and usually inadequate reduction of the height of the posterior leaflet during the OR. It's the main cause which pushes the anterior leaflet toward the LVOT. So this is a picture. This is during diastole. This is the anterior and this is the posterior leaflet. So during systole, what happened that when you have an excessive height of the posterior leaflet, it will push the anterior leaflet toward the left ventricular outflow tract that will cause LVOT obstruction and severe mitral regurg. This is usually a risk factor is increased redundancy of the posterior leaflet and small annuloplasty ring. It is relevant in patients with true bileaflet prolapse like in Barlow disease or with extremely enlarged anterior leaflet. So the height of the posterior leaflet must be meticulously carried out in maximatis valve disease, and upsizing of the ring is used rather than downsizing of the ring should be done. What are the echocardiographic details that are associated with high risk of SAM preoperative? So when you see that the mitral valve coaptation line is proximal to the intraventricular septum, or when you have an asymmetry between the anterior and the posterior leaflet, or if the posterior leaflet is relatively large with respect to the anterior leaflet, or when the P2 portion of the posterior leaflet is larger than the medial portion of the A2. So the management of the SAM mainly is conservative, with starting with adequate volume, reducing tachycardia, reducing inotrope. And if this doesn't work, then we go for the surgical option, which we can remove the annuloplasty ring and consider either sliding annuloplasty or implanting an incomplete mitral annuloplasty ring, increasing the size of the anterior posterior diameters, or we can use an Alferi stitch edge-to-edge technique to reduce the risk after lowering the height of the posterior leaflet. So remodeling ring annuloplasty. So there is a debate what type of ring we should use. Already Dr. Has elaborated about that, but just to follow up, rigid, soft, or complete. So it's not critical what type of ring you should use for maximatis, but as long as it's upsizing and secure attachment to the trigone, that's the most important thing. There are some evidence that suggests flexible ring may cause less possibility of SAM than the rigid one, but it's not being proven. So how do you know that you have placed a correct ring? The suture should be parallel to the annulus at the junction of the posterior leaflet and the annulus. It should be deep and orthogonal to avoid injury to the LCX. And the suture are not budgeted unless there is extreme fragility of the annulus structures. So sizing, as we said, is done by two techniques, either intertrigonal distance, but this is usually may cause downsize of the ring and cause SAM or ring dehiscence. So it's better to use the height of the anterior leaflet from the annulus to the highest point on the leaflet when it is stretched. So this is what we have for the maximized mitral repair. Now we will go for rheumatic. Before I go to the rheumatic, is there any question? Okay, so for the rheumatic mitral valve, so pathophysiological implication of the rheumatic mitral disease, the main consequences of the rheumatic heart disease is the mitral stenosis, which will increase the diastolic gradient across the mitral valve. From the hemodynamic standpoint of view, transvalvular flow and heart rate are very important because when you increase the cardiac output or when you have a fast heart rate, the gradient in the mitral area will increase. Increasing this gradient will trigger the left atrial enlargement, and this will cause to atrial fibrillation, annular dilatation, thrombus formation, and logic rise in the pulmonary hypertension. So a surgical consideration. Now, most of the patients with the mitral valve stenosis are receiving a balloon valvoplasty unless the lesion are not amenable to balloon dilatation. There is a concomitant mitral regurg, or we have a previous balloon valvoplasty has failed. However, as repair has been shown 100% repair in a maximized disease, it's only feasible in 50 to 75% of patients with rheumatic valve disease. So for pathophysiology, we have three types of dysfunction in the rheumatic mitral disease. Type 1 dysfunction, we have a pure annular dilatation with LV dysfunction that is caused by the pancreatitis and ventricular dilatation due to myocarditis, and this will cause to atrial fibrillation. The other pathological consequences of the mitral disease, type 2 dysfunction, we have either a true prolapse or a pseudo prolapse. The true prolapse, the leaflet override the coaptation plane during systole, resulting in mitral regurg, and the pseudo prolapse is secondary to lack of coaptation between the anterior and posterior leaflet without overriding the plane of coaptation. So in type 1 and type 2, you have a mitral regurg rather than mitral stenosis. In type 3 dysfunction, which is the most frequent type of dysfunction, you will have stenosis with severe regurg. The pathophysiology is you will have the leaflet fibrosis and the thickening of both leaflet, as well as the fusion of the commissure will lead to restricted leaflet opening that will result in mitral stenosis, and restricted motion of the fibrosed leaflet that will lead to severe mitral regurg. When you have a restricted motion, mainly affecting the valve opening during diastole due to commissural fusion, this will give you a predominant mitral stenosis. So we'll have the same setting, the same median sternotomy, the same valve exposure through the sandograph techniques, and then we'll do valve analysis to assess the availability of the leaflet tissue and assess the lesion, the jet, and the calcium. So you can have one of the three or all of them. You can have a chordal fusion with a chordal retraction. You can have a leaflet thickening with a leaflet restriction, and you can have a commissural thickening, which is 3 types. So for the mitral repair techniques and the rheumatic mitral valve disease, all patients will need to have a prosthetic ring or a band, because regardless of the etiology of the mitral valve disease in the rheumatic heart disease, most of the patients will have annular dilatation. So the use of annuloplasty ring has been shown to reduce the incidence of both mitral and tricuspid regurg in patients with rheumatic valve disease. Also in the patient with pure mitral stenosis with obvious annular dilatation, the ring annuloplasty will contribute to prevent commissural leak by providing better surface coaptation area for both leaflet. So surgical technique for the rheumatic disease, we have commissurotomy. The first of all, traction of the anterior leaflet will identify the commissural line. Then with the 11 blade, an incision is made about 5 millimeter from the annulus. And then the incision is extended to the papillary muscles with preservation of the both chordae on either side. That's all. And we have another technique we have is the leaflet resuspension, the fibrosis and the fusion of the subvalvular apparatus. So what we'll do is the splitting of the papillary muscle, as well as resection of the marginal chordae and replacement of the new chordae. The last technique we have is leaflet augmentation by epicradial patch. After retracting the leaflet, An incision is made about 5 millimeter parallel to the annulus. Then a secondary chordae is resected to free and resuspend the leaflet. Then a semilunar autologous pericardial patch is attached to the leaflet from both sides and adding 2 millimeter margin for suturing. Then an oversized ring is done to fully accommodate the posterior leaflet. So outcome of the repair of the rheumatic mitral valve disease, particularly in a pure or concomitant mitral stenosis, cannot be done. Okay. This is wrong. Okay. The operation rate are higher in patients receiving mitral valve repair, mainly due to fibrosis and calcification of the subvalvular apparatus and the disease progression. So the estimated failure rate of mitral valve repair in patients with rheumatic valve disease is 2 to 5% per year versus 1 to 2% in patients with degenerative valve disease. So the reoperation is higher in the rheumatic valve disease, and the repair is 50 to 75% amenable in the rheumatic valve disease patients. Thank you.
Thank you, Doctora. It's a great effort for you.
Thank you so much. Okay, so I have questions and some comments. Okay.
Okay.
So what are the 4 principles of repair? When you say I'm going to repair a valve, what are the 4 important principles about successful repair?
So you mean the exposure and the
No. Just like to have a successful repair. You finish your repair. What are the 4 most important things you really look for?
But if no regard the shape of the valve, like the smile face of the posterior leaflet. كده قصدك؟
So first of all, you need to have a normal mobile anterior and posterior leaflet.
Okay.
You need a coaptation line of 4 millimeter and above. You need to have fixed anterior mitral leaflet with a ring, and you need to see the smile shaped mitral valve. This is the 3 important things, or the 4 important things in the principles of mitral valve repair. Now, talking about different repairs, you can talk till tomorrow. There's too many repairs. Caudal transfer, artificial cord, resection, papillary muscle shortening, papillary muscle sliding, papillary muscle sling. There's a lot of techniques. But the most important thing, you do the technique that you're comfortable with. Okay. In terms of rheumatic mitral valve repair, look, the outcomes, it depends on the experience. There is a very good surgeons, especially in Malaysia and in Indonesia, when they have because they have a lot of rheumatic heart disease and a lot of patients they come. This is very important in young females when you operate in young female, because they need to go for pregnancy. They don't like to use accommodant, all these kind of things. So rheumatic mitral repair, it can be done. The principles of rheumatic mitral valve repair, it has like also some principles. Number 1 principle, you have to do a commissuration. You have to release the commissure. That's number 1. Number 2, you have to also dissect all the subvalvular apparatus. You'd like to make the leaflet mobility better. You need also to resect all the calciums and the calcium debris from the leaflet of the valve. And after that, you need to make the anterior leaflet mobility better, because one of the principles of the rheumatic mitral valve repair is to fix the posterior leaflet, fix the posterior leaflet and keep the anterior leaflet mobility. What we can do for a rheumatic mitral valve repair, you can actually deattach the whole anterior leaflet and maintain its attachment to the papillary muscle. Then take the measurement from commissure to from triangle to trigon, and then take the valve sizer or the ring sizer, and then fix autologous pericardium, and then augment the anterior mitral leaflet to make it like a cell, like. And then after that, you can put a ring to stabilize the annulus. The most important thing when you embark on rheumatic mitral valve repair, you need to have very good mobility for the anterior motor leaflet, because this is it's going to work for you. Posterior motor leaflet will be like, it's just like a bumper, you know, just to maintain a cooptation with the freely mobile anterior leaflet. For the SAM, you mentioned a very good echocardiogram criteria, but I have to add one or two. You have to look for aortomitral angle. You know, when you look at that 2 or 3 chamber view in the TEE, you have to look at the angle between the mitral valve annulus and aortic valve annulus. If this angle is less than 120, this also gives you a higher risk to go into SAM. Posterior mitral leaflet length more than 1.5, this is another high risk of SAM. Also, if you have a narrow LVOT, because the idea of SAM that the anterior leaflet will be rolled down, because the cooptation, you push the cooptation anteriorly toward the interventricular septum, and that's why the anterior leaflet will roll and will go into the LVOT and cause obstruction. I think that's all. And if anybody have questions or comments, we'll be happy to hear. Thank you. Very good presentation. Excellent work. Thank you.
Thank you.
Okay, thank you, Dr. Rasha, for this presentation, and thank you, Dr. Muhammad, for these nice comments. So if anyone has any question, or we'll have a quick break till 3 p.m. so we can start the second lecture.
Okay, guys, thank you so much.
يعطيك العافية دكتور محمد، شكرا جزيلا.
Hello.
Hello, hi, Doctor.
Alan, good morning.
Good morning. So, good afternoon, everyone, and welcome back. So, I would like first to welcome Dr. Ismail Hamamsi, who was humble enough to accept our invitation today. So, for those who doesn't know Dr. Ismail did his residency at Montreal University, and then he took a trip across the Atlantic to join Sir Majdi Yaqub, where he did his fellowship there, and then back to Montreal, where he established the Aortic program. And recently he is currently at Mount Sinai Hospital, New York. So again, would like to welcome Dr. Ismail. And without further ado, the mic is yours. Thank you.
Thank you, Luay. It's a real pleasure for me to be with you today. Unfortunately, I would have much preferred being there live, but things being what they are, it's still a real honor and privilege to be among all of you. I recognize some names in the attendee list, and again, I hope one day we can meet in person again. Let me just share my screen. So, as discussed with you, the topic of my presentation today will be aortic valve surgery in young adults, and we'll explore the different options from repair to replacement and the Ross procedure. Can you see my screen in presentation mode?
Yes.
Okay, great. And please feel free to interrupt at any time during the presentation. If you have any questions, I'll be happy to take them as we go along. So as Luay mentioned, it's been almost 15 years since I started working with Professor Yaqub in London in 2006 that I've been particularly interested in the topic of aortic valve surgery in young adults, and especially the role of valve repair and the Ross procedure. And what I'll walk you through today is hopefully trying to cover some of the points that have become quite obvious in the last 10 years or so, with accumulating evidence from the literature as to how best to manage these patients. These are the two case scenarios which we'll be discussing today. One is a 53-year-old patient with severe aortic stenosis, normal ejection fraction, and you can see his valve on the echo images is quite calcified, and the gradient is significant, and the patient is symptomatic. How do we best manage that patient? Is it a mechanical valve? Is it a tissue valve for a valve-in-valve? Or is it alternatives? And likewise, this is a 36-year-old patient with no previous medical history who presented with bicuspid, severe AI, and a root dilatation measured at 51 millimeters. Again, how do we best approach it? Is it a biobentol? Is it a mechanical bentol? Or is it other options? As you notice, both of these patients are young patients. They're very different from the majority of patients we treat with aortic valve disease in their 70s and 80s. Younger patients are different in that they have a higher level of physical activity. Quality of life is obviously very important for any young patient. They usually have young families, they are professionally active, they need to travel to be able, it has to be compatible with all their professional and personal aspirations. But the most important difference between a 75-year-old and a 45-year-old is the fact that they have a longer anticipated life expectancy, which translates into a longer potential exposure to valve-related complications. And that is degeneration and reoperation with tissue valves, or bleeding and thromboembolism with mechanical valves. So my first point in this presentation this morning is to show you that data about aortic valve replacement in the young shows that it is associated with excess long-term mortality when we use prosthetic valves, whether they be mechanical or tissue valves. Now, that being said, there are many advantages to using a mechanical or a biological valve. They are very standardized procedures. They're very easily reproducible. They come with very short operative times, And we also have long-term data to support their use. But when we look at the long-term data, their use is mostly supported in the older patient category. When we look at the younger patients, the data is a bit more sobering, and it gives a bit more pause before we say that it really is the treatment of choice. This is a study coming from Sweden that now dates back some time, but it's still very relevant because in Sweden they have a registry where all patients who undergo heart surgery go into the registry and can be followed longitudinally over time in terms of at least life and death events. And what they looked at was the difference between observed mortality in black and expected mortality in white in the age and sex matched Swedish population after mechanical or biological aortic valve replacement. And what you notice is that about 7 years after surgery, there starts to develop a difference between the observed mortality in black and the expected mortality in white in these patients. These are all comers, patients of all ages. So when you look at a graph like this, you may intuitively think that this is mainly driven by the older patients because maybe they have other conditions, and that's why the gap is wider. But if we look simply at younger patients, maybe that's not the case. Well, they actually stratified the patients according to their age at the time of surgery, as you can see here on the left-hand side. And what they showed was the OE ratio, the observed to expected ratio in terms of deaths. And surprisingly, patients under the age of 50 had the highest OE ratio at 4.5, whereas patients over the age of 70 had an OE ratio of 1. In other words, over the age of 70, mortality in the patients after AVR long-term was exactly identical to the age-matched population, whereas in patients under 50, it was 4.5 times higher than would be expected in the matched population. So in other words, the younger the patients were at the time of surgery, the higher that excess mortality is in the long term. Looks a bit surprising. So when I started my practice in Montreal, together with Ismail Bouhout, who was one of our residents at the time, who is now doing a congenital surgery fellowship here at Columbia University, we decided to look at outcomes of isolated elective mechanical AVR in young adults, patients under the age of 65 years of age. And we excluded anything that we thought had an impact on long-term outcomes. So patients undergoing concomitant procedures, coronary disease, redos, dissections, endocarditis. The mean age of the patients was 53 years old, so just like the patient I showed you at the beginning of the presentation. And the mean follow-up was 9 years. So quite a long follow-up with good completeness of follow-up. And again, if we compared their survival versus the age and sex-matched general population, you can see that at 10 years, there already is a difference in the survival, and that gap continues to widen as the years go by. Again, remember, these are patients that were 50 at the time of surgery and highly carefully selected. In fact, when we combine reoperation, which is a rare event, but still it's not 0% after mechanical AVR, and mortality, survival free from reoperation at 10 years only was 82%. In other words, at 10 years after isolated mechanical AVR, 1 in 5 patients was either dead or reoperated. And this was mainly driven by death rather than reoperation. Not perfect results. Well, one may argue, well, today we're putting more and more tissue valves because we can do valve-in-valve maybe in the future, and the valves have become maybe better as well. Well, this is a study from the Cleveland Clinic looking at 3,000 Fairmount valves, and their conclusions were very similar. Younger patients had worse than expected survival that was further diminished with insertion of a small prosthesis, underlining the importance of patient prosthesis mismatch in young patients as opposed to in older patients. This is another study coming from France of over 2,500 patients undergoing tissue aortic valve replacement. And again, what they did is they stratified the patients according to their age at the time of surgery, as you see here on the x-axis. And they looked at the observed survival in black versus the expected survival in the age and sex matched French population in gray. And you can see that over the age of 70, patients had a survival that was almost identical to the expected survival in the population. But the younger the patients were, the bigger the gap became between observed and expected survival in these patients. Again, exactly like that Swedish study I showed you, and similar to the Cleveland Clinic data. And again, from that same group, when they zoomed in on patients between the ages of 50 and 65, and I'm saying this for all the trainees here in this talk, they looked at the median durability of a tissue valve in patients in their 50s. So looking at freedom from structural valve degeneration. And what they show in this graph is that the median durability is almost 18.5 years with a tissue valve in that age group. That sounds like a very good proposition if you tell a 55-year-old patient that his valve will last until he is in his 70s before he needs his valve-in-valve procedure. But the reality is that almost half of these patients were dead 15 years after surgery. And death and structural valve degeneration are competing risks. If you're dead, you will never have structural valve degeneration. You will never have a reoperation. So it's always important to keep an eye on survival before you simply look at the freedom from structural valve degeneration, and before the companies tell you that their new generation valves now last very, very long time. And again, young patients are very different from old patients in terms of survival. And the last study I'll show you with regards to conventional aortic valve replacement in young adults is this one, which was recently published in the New England Journal of Medicine, where they analyzed data from the entire state of California over a period of 15 years. And they had almost 10,000 isolated AVRs in patients under the age of 65. And they stratified them according to age, patients 45 to 54, and looking at their 15-year mortality ranged between 26 and 30%, whether they had a tissue or a mechanical valve. Again, 1 in 3 patients to 1 in 4 patients was dead 15 years after surgery. And these were isolated AVRs. Same thing between the ages of 55 and 64, a third of the patients were dead 15 years after surgery. This is definitely not in line with expected survival in the general population. We wouldn't expect a third of patients age 60 to be dead 15 years after surgery. So I think the message from all these studies, and there are many more in the literature, really all of them being published over the last 10 to 15 years, is that conventional aortic valve replacement in young adults is far from being a curative approach. It is at best a palliative approach. And so that's why we need to think about other options or alternatives if we can improve on some of these results. But if we want to improve on some of these results, we need to understand why we are observing this survival that is perhaps not as good as we thought we might be doing after surgery. And I think the reason is twofold. One is hemodynamics, and two is biology. And my first point is we really have to think patient prosthesis mismatch anytime we're doing aortic valve surgery, especially in these younger patients. And patient prosthesis mismatch is a very prevalent problem after aortic valve surgery. This is a recent review by Catherine Otto showing that almost 40 to 45% of patients who leave the hospital after aortic valve replacement have either moderate or severe patient prosthesis mismatch. How relevant is patient prosthesis mismatch? This is data from the original studies by P. Barlow in Quebec, in Canada, showing that patient prosthesis mismatch has a direct impact on long-term survival of patients, especially on younger patients versus older patients, and especially severe mismatch versus moderate mismatch. So we really have to be very careful about trying to avoid mismatch at all costs in these patients. And you will hear more and more that perhaps TAVI now is a very good solution for patient prosthesis mismatch because there's no stent to the valves, and therefore the hemodynamics are probably better. But the reality is different. This is the data from the PARTNER 3 trial. And when you look at the incidence of moderate or severe mismatch in both groups, it was actually very similar between the two groups, if not higher in the TAVR group, with 34% of the patients in TAVR having patient prosthesis mismatch and 30% of the patients in the surgical group having a PPM. So PPM is still, even to this day, although many of the surgeons involved in this trial were aware of the importance of putting in large valves and avoiding PPM, it remains a very prevalent problem. And in fact, when we look at the 2-year echocardiographic data from the PARTNER 3 trial, I'll just draw your attention to this one line, which I think is very relevant. This is the incidence of mean gradients over 20 in these patients. So patients who are now in the moderate stenosis range only 2 years after the procedure. And if you look at the incidence in the TAVR group, it was already 10% of the patients that had moderate stenosis after their TAVR procedure versus 5% in the surgery group. These are patients that were age 74 at the time of surgery. It's not even relevant to the specific topic of this presentation, which is patients in their 40s and 50s, but one can only surmise that this 10% would be even higher in these younger patients. So before you get too discouraged about the role of surgery, particularly in young adults, look carefully at the data. I think a lot of the data around TAVI is not as glorious as it's made to sound. And the second point, I mentioned biology. And we have to remember that the aortic root is a living structure. For a long time, we thought the aortic valve was just a passive open and close valve, but the reality is very different. And as some of you may know, I spent 4 years in London under the supervision of Professor Yaoub, and the title of my PhD thesis was The Living Aortic Valve. So I really spent 4 years in the lab trying to understand how these aortic valves function, their cellular, the molecular mechanisms, and how this relates to surgical outcomes. And I won't bore you too much with this, but just a couple of slides to show you how sophisticated aortic valves are. This is a cross-section of an aortic valve cusp, and you will notice that it looks very much like a blood vessel. It has a single layer of endothelial cells on both the aortic and the ventricular side. It has a mixed population of cells inside the body of the leaflet, which we call interstitial cells, which is a mixed population of smooth muscle cells, fibroblasts, and myofibroblasts. If you have smooth muscle cells, it means that the leaflets can contract and relax, and the fibroblasts are there to continuously repair and regenerate the extracellular matrix. And the extracellular matrix itself is very well conserved across humans and species, with mostly collagen on the upper side and elastin on the lower side of the cusps to allow these leaflets to expand during diastole and to bear the diastolic pressure. And between the two, there's a population of proteins called glycosaminoglycans, which are water-rich proteins that allow these layers to slide against each other without any friction or trauma during the cardiac cycle. A normal aortic valve cusp measures about 300 to 500 microns in thickness. That's just a half a millimeter in thickness. It opens and closes over 100,000 times every single day, and it has to adapt to varying hemodynamic conditions. It's a real work of creation, and certainly nothing that an artificial valve can replicate. In fact, if we look even deeper in aortic valve cusp, we see these neurofilaments in the body of the leaflets, and their function still remains very elusive, but their presence again testifies to the complexity of these aortic valve cusps in terms of structure and the sophistication of their functions. And we and others in the lab did many studies to try to understand how aortic valve cusps adapt to different conditions. And this is just one study that I'll show you, where we took aortic valve leaflets, we put them in a biaxial mechanical testing system that allowed us to look at contraction and relaxation responses, but also at the changes in elastic modulus of the leaflets. In other words, can they become stiffer or more relaxed in response to different endothelium-dependent agents? And it was really fascinating what we found. We found that aortic valve cusps have different mechanical properties in their radial and circumferential directions, just by virtue of the alignment of the smooth muscle cells and the extracellular matrix. Aortic valve leaflets can relax and contract in response to different agents, exactly like blood vessels do when you put them in organ chambers. But even more fascinating was the fact that aortic valve cusps can become stiffer or more relaxed in response to different endothelium-dependent agents. For example, when we added endothelium to the bath, the cusps became much, much stiffer, mimicking a situation of primary hypertension in the body where they have to bear a higher diastolic pressure and a higher diastolic load. Again, all of this is just to highlight the fact that aortic valve leaflets and the aortic root is not a passive structure. It is a living, adaptive, and very dynamic structure that is very important for many functions around the heart during the cardiac cycle. But for us clinicians, what does that mean? That means that we have perfect laminar flow with excellent hemodynamics through a normal tri-leaflet aortic valve, both at rest and with exercise. We have low thrombogenicity because these endothelial cells can produce nitric oxide, which prevents platelet aggregation. So that's why in a normal aortic valve, we don't need to have any antiplatelets or obviously any anticoagulation. And finally, good resistance to infections, because these cells, anytime there's bacteria in the blood, can call for an inflammatory reaction, which can help the leaflets fend themselves against infection. And when we look at late outcomes after aortic valve replacement, all of these features, the type of flow, the presence of mismatch, the need for anticoagulation, the likelihood of having valve-related complications such as endocarditis, all of this is what determines clinically relevant outcomes such as survival, valve-related complications, or even quality of life. And so the proposition is that having a living aortic valve or a living aortic valve substitute in the aortic position with unique biological and hemodynamic features would translate into improved clinically relevant outcomes. And there are two ways we can either keep a living valve or substitute it with a living one. One is repairing the aortic valve, and secondly is replacing the aortic valve with the patient's own pulmonary valve or doing the Ross procedure. And I'll touch briefly on aortic valve repair and show you some techniques, and then dive a little deeper into the Ross procedure. Again, of course, time is limited today. So for those of you who are interested, this is a focus issue on advanced techniques in aortic valve repair, which I had the pleasure of co-guest editing with Emmanuel Lansac from France, which was published a year or two ago, and really very comprehensive focus issue on aortic valve repair, both in terms of indications, techniques, and pitfalls. And this is a recent review on the current concepts of bicuspid aortic valve repair, which I invite you to look at. But going back to the patient that I showed you earlier, the 36-year-old patient, you can appreciate that she has a bicuspid aortic valve. You can appreciate its right and left fusion here. There may be a bit of thickening around the raphe, but there's good mobility and excursion of the leaflets. There's a typical jet of aortic regurgitation, which is directed towards the anterior leaflet of the mitral valve, so an eccentric jet, suggesting some prolapse of that fused leaflet. And there is an element of annular dilatation and root dilatation. So the plan in this patient would be, one option would be to replace the root and the aortic valve, doing a Bentall, but alternatively, it would be to preserve her valve and repair it. And I'll just show you a brief video of this surgical technique. You see the mobility of the leaflets is acceptable. This is a 36-year-old patient. So the first step is examining the leaflets, making sure there's no big calcification or fenestrations or retraction. And then the next step is making sure that there is no prolapse of the reference leaflet, in this case, the non-coronary. And then we do the leaflet work after having mobilized the roots. We release the raphe, which gives the leaflet a bit more mobility. And then before doing any leaflet work, you place the subannular sutures from inside the LVOT to the outside using 2-0 plegited ethibond sutures. They go in a circumferential plane in the basal ring, and you see their position in a horizontal plane. And these will be used for the annuloplasty after we finished replacing the root. Now, before doing the remodeling, we do the leaflet repair first. And here I'm just mimicking once we fix the leaflet. Remember, the commissures here will be positioned at 180 degrees. And so all you're trying to do is really to make both lengths of free margins equal in between the non-fused and the fused leaflet, as well as correcting the prolapse of the fused leaflet. And these central plication sutures will do both of these things at the same time. They shorten the length of the free margin and they correct the prolapse. And you can see with the LV vent, when you suck, the leaflets become completely competent after the valve repair. And then the next step is doing the remodeling of the root. You can also do a reimplantation technique. I think a remodeling with annuloplasty provides a much more physiological repair, all the while stabilizing the basal ring. So cutting these tongues at 180 degrees and creating two tongues there, we start the remodeling procedure. And it is very important on the aortic side to really go at that hinge point to exclude all of this residual aorta. And then as you work your way towards the commissures, you keep extending that cut through the graft to wherever the commissure wants to sit. I take wider bites in the grafts to create sinuses of Valsalva. You can appreciate here these sinuses and the valve being competent on the inside. Once that is done, then we pass the sutures through the ring. This is a Dacron ring. You can also use the Coroneo ring. And the sutures are tied, which then does the annuloplasty at the bottom. And you can see there's really no residual aorta that can dilate. So this is what it looks like once it's done. And you can see these sinuses of Valsalva. This is valve function. You can see good mobility of the leaflets and absence of any residual regurgitation in this patient. Importantly, when we do valve repair, this is my personal series of almost 300 patients now. And when you follow them over time, you can see in blue is the average mean aortic valve gradient across these aortic valves. And it always remains in the single digits. Only a few patients have gradients in the double digits, but the vast majority have very low gradients, both at rest and with exercise. And in terms of durability, or in terms of cumulative incidence of recurrent AR, it remains rather acceptably low at 5 years. And this is the largest long-term data of bicuspid aortic valve preservation. This is data from Schaefer's group in Germany of almost 1,000 patients undergoing bicuspid valve repair. And looking at survival of these patients versus the general population, they showed survival that was identical up to 15 years to that of the German general population. Again, very different data from what I showed you with aortic valve replacement with mechanical or tissue valves. But the question is, what do you do when the bicuspid valve looks like this, and you cannot repair it, and you cannot preserve it? What is the role of the Ross procedure in that context? The Ross procedure, for those who may be a little less familiar, consists of harvesting the pulmonary root from the right side. The idea being that the pulmonary valve is a mirror image of a normal tri-leaflet aortic valve, implanting it as a total root on the aortic side, and then replacing the pulmonary root with a pulmonary homograft, so a cadaveric pulmonary root. It is the only, this is a picture of a pulmonary autograft or a pulmonary valve after it's been harvested. And you can see the 3 sinuses, you can see the 3 leaflets. It looks exactly like a normal aortic valve. Importantly, it's the only operation that guarantees long-term viability of the aortic valve and root. We have explants up to 30 years after the Ross procedure. And when we look under the microscope, we can see that same trilaminar structure that I showed you earlier with endothelial cells, interstitial cells, all of it remains preserved even 30 years after the operation. As you know, the Ross is not a new operation. It was actually described in 1967 in this paper by Donald Ross, who was a South African surgeon practicing in London at a time when they actually had very few alternatives for aortic valve replacement in patients. The only options really were an aortic homograft or a new technology, which were cage and ball mechanical valves, which did not perform very well, were very thrombogenic. And so patients, they were looking really for alternatives. And he came up with this brilliant idea of taking the patient's own pulmonary root and putting it in the aortic position, because what they saw with the aortic homograft was very early failure, especially in young patients with rheumatic disease, which was the majority of patients undergoing heart surgery in the 60s and 70s. I'm sure many of you have heard some of these comments around the Ross procedure. Either I don't believe in the Ross, or they all come back for reoperation, or why don't we just put a large tissue valve and then come back for a valve-in-valve procedure? And once again, you know, because our time is limited this morning, I will only focus on some aspects of the Ross. But for those of you who are interested in a more comprehensive view of the Ross, this is a state-of-the-art review we published in JACC a couple of years ago. Amin Mazin, who was a student in Montreal, who's now a resident in Toronto, authored this review with many co-authors, and it's an excellent work he did and very comprehensive. What I will do today is simply focus on survival data that has been published over the last 10 years. Why? Because survival is really a binary outcome. You're either dead or you're alive. It's a very hard outcome. It's not like a 6-minute walk test or NYHA score or some of these less precise outcomes. And this is the first study I'll show you, one of the few prospective randomized trials in the literature, at least in our open valve surgery literature. And this is a study that Professor Yacoub had undertaken in the 90s, where he was comparing the use of a Ross procedure versus aortic homografts in young adults with aortic valve disease. The reason why aortic homografts were used as the control group is because of their hemodynamic results. And hemodynamics in the 90s was thought to correspond to better durability when putting a homograft or a tissue valve, and bioprosthetic valves were still not quite up to speed in terms of their performance in young adults. And so these patients were aged 39 at the time of surgery. He randomized 216 patients. And these were not careful, I mean, these were not cherry-picked patients. They were really all comers. If you look at the incidence of patients that had active endocarditis as an indication for surgery, it was 8% in both groups. And almost half the patients had a previous operation, the most frequent of which was homograft aortic root replacement. So by no means were these easy operations, and by no means were these patients destined to have a very good long-term outcomes. And yet, when we analyzed the long-term outcomes of these patients, looking at 13-year survival in the Ross group in green, it was exactly identical to the UK sex and age-matched general population, as you can see here in the black curve. Whereas patients undergoing homograft root replacement had a significantly lower survival at 13 years, just like we saw with biological valves or with mechanical valves. So this was really the first study that brought forth the notion that perhaps there is a way to restore survival, long-term survival after aortic valve replacement. So other groups then analyzed their data. This is the Toronto data, Tyrone David series of 212 patients undergoing the Ross procedure. The average age of the patients was 34 at the time of surgery, and the mean follow-up was 10 years. And if you look at 15 years, the survival was exactly identical to the Ontario's age and sex matched general population. In fact, 4 years later, they updated the series with now a median follow-up of 14 years, so pretty long-term follow-up. And again, survival here on the left side, exactly identical to the general population. And in fact, when they looked at survival free from reoperation at 20 years, it was around 75%. But as you can see here, it was mainly driven by reoperation rather than death, as opposed to what we saw with mechanical AVR, which was mostly driven by death rather than reoperation. Again, 75% survival free from reoperation at 20 years in patients aged 34 is a pretty remarkable outcome, all things considered. Well, you may say, Magdi Yaoub, Tyrone David, these are master surgeons. What about the rest of us? Well, the Germans put all their data into a German registry that now includes, it actually now includes almost 2,500 patients. Their most recent data will be published in JACC in the next few weeks. But this is their latest publication was in 2016, 1,800 patients. The mean age was 45, and the mean follow-up was 8 years, but a third of those were followed for more than 10 years. And at 15 years, survival was exactly identical to the German general population. And the data now up to 25 years shows a continued survival exactly identical to the general population, as you will see in that paper in JACC. This is another study coming from the UK, where they have a national registry. They analyze patients between the age of 18 and 40, and looking at survival free from reoperation using propensity matched analysis, they showed that Ross had better outcomes than mechanical, which had even better outcomes than tissue aortic valve replacement. This is yet another study coming from Australia of 400 Ross cases, where they performed a propensity matched analysis with mechanical AVR, 275 pairs, mean age was 43, and looking at 20-year survival, there was almost a 10% difference in survival between these patients in both groups. And this is from that review by Amin, many more studies. I'm putting the countries here to show you that they come from different continents and different countries. All of them have mean follow-ups in the double digits, so pretty long-term follow-up. And all of them, where you see a little cross here, is survival that is identical to the general population. And almost all the studies confirm that restored survival versus the general population in the long term. So I will submit to you that the Ross is the only replacement operation that to this day has shown restored long-term survival after replacement of the aortic valve. But obviously, as you know, its use has really dwindled in current practice, although there's a definite revival of the operation in the last 5 to 10 years based on all this evidence that I just showed you. But why is it that we are not performing as many Ross procedures today? And I think the Achilles heel is twofold. One is the surgical complexity, which means perhaps higher surgical risk for patients. And as you know, these are all young patients in whom you expect the mortality to be very close to 0%. And secondly, maybe issues with durability of the operation and the need for reinterventions in the long term. And I'll show you that both these points are not as black and white as one may think. In other words, I think both of them can be addressed, and there have been improvements to really improve on these results, both in the short and the long term. And in terms of surgical risk, I will simply show you my personal aortic reconstructive series focusing on the Ross procedure. And the reason I show you this is because I think there are many lessons that can be learned for young trainees or young surgeons starting their practice or considering starting, aortic reconstructive programs. This was our experience at the Montreal Heart Institute in the early 2000s with either Ross, which we didn't have a program, or valve sparing or aortic valve procedures. And as you can see, I started my practice here in 2010 and gradually started both an aortic valve and reconstructive program, as well as a Ross procedure program over the years. But why I'm showing you this is because I will show you the operative results of this entire series, which includes not only my learning curve as a surgeon and for us as a center with the Ross procedure, but really my learning curve also as a young surgeon starting his independent practice. The one thing I'm most proud of is that all of these patients, almost all, have annual clinical and echocardiographic follow-up up till now, And this is the team that follows these patients. Even though I'm gone, they continue to follow them. And this will be very important for informing what we do in the long term, both the things that work and the things that do not work. But going back to the Ross series, these are almost a little over 500 patients. The mean age of the patients was 48 at the time of surgery. And you can see it ranged from 16 to 67, with the majority being in the 40s and early 50s. 15% were redos, and 6% had active endocarditis. So again, these were not just very cherry-picked patients, but really carefully selected, but all kinds of patients. Operative mortality was very comparable to regular aortic valve replacement, with 2 patients dying perioperatively. One was a third redo. The other was a patient who required double valve replacement for mediastinal radiation disease. Importantly, both of these mortalities occurred early in the experience. And since 2013, we've had, knock on wood, no mortalities after the Ross procedure. So there definitely is a learning curve, and that's why it's important to have a committed team around you of surgeons, intensivists, anesthesia, perfusion, who are ready to work with you and who believe in the evidence that you present. But as you can see, in the first 100 patients, we had more complications and both our mortalities. But you can see that with experience, both for the individual surgeon as well as for the team, the incidence of complications and mortality really go down quite dramatically from that point on. And Ismail Buhout had published a paper looking at the learning curve for the Ross, and it sits right around 75 patients, before which really all of these outcomes become really much, much better. And that is very similar to any complex operations. The learning curve for mitral valve repair has been established at around 70 cases, and for valve sparing root surgery between 75 and 100 cases. Survival up till now is exactly identical to the age-sexed general population. But what is interesting is if you look at hemodynamics, the mean indexed effective orifice area of these patients at discharge is 1.5 centimeters square per meter square, with a range of 1 to 3 square centimeter per square meter. In other words, no patients had either moderate or severe mismatch in this entire series, including some patients that we had to reoperate on because they had a small prosthetic valve and patient prosthesis mismatch, who left the hospital with a mean gradient under 10. The mean gradient at discharge was 5. And another important feature is that the pulmonary valve does not calcify or degenerate like a normal bioprosthesis does, and therefore that low gradient at the beginning remains low over time and over the years. And we recently did a study where we looked at gradients with exercise, and the gradient almost does not move when patients exercise across a pulmonary autograft. Sorry, I showed you these slides already. Yeah, and this is the study I was mentioning earlier, where we use this ergometer, which is MRI compatible. It's called the RAISE trial. The data is just completed, so we are now analyzing it. But we examined not only gradients, but also the strain on the left ventricle in patients after the Ross procedure or mechanical aortic valve replacement to understand how the ventricles perform, because I think this is really where the answer lies in terms of why the survival is so different between these two groups. And the last point, or the second point or weakness, one may say, of the Ross may be the durability. And indeed, if you look at the literature, there are studies that show high rates of reoperation in these patients, even within 10 years after surgery. This is a study from Rotterdam showing high rates of reoperation in adults, and that, in their conclusion, led them to abandon the use of the Ross procedure in adults. However, they also examined why these patients came back and what the behavior of their autograft roots were. And the main reason why patients come back for reoperation, at least on the left side, is because of dilatation of the pulmonary autograft root when you put it in systemic conditions. What they noticed was that most of the diameter increase was already reached at hospital discharge, with diminished increase thereafter. In other words, within a week of surgery, the autograft had already dilated quite a lot, and that got more dilatation to go. So the first lesson is that early dilatation begets dilatation and requires reoperation in the long term. But the second point is that technique really matters when it comes to the Ross procedure. It matters not only to keep the operation safe, but it really matters to keep the operation durable in the long term. This is a paper which I invite you to read. It was written by Amin Mazin and Ali Ghonem. Both were excellent residents. Amin now is in Toronto. Ali just completed his residency at McGill, and both brilliant future surgeons. But really, we need to understand the differences between the aortic route and the pulmonary route to understand how to improve results with the Ross procedure. In fact, understanding anatomy is really the basis of any reconstructive valve or cardiac work one can do. So I really invite you to spend time in the anatomy lab or get animal hearts and really dissect them inside out to better understand the things we do and why some work and some don't work. And the main difference between an aortic valve and a pulmonary valve is that the aortic valve has a fibrous portion to the annulus, which really gives it good structural strength. The other feature is that the aortic valve lies within the fibrous skeleton of the heart, and therefore it is supported by rigid structures that prevent dilatation in the majority of cases. The pulmonary valve is the only one of the four valves that does not sit within the fibrous skeleton of the heart. Instead, it is elevated upwards by the infundibular muscle of the right ventricle. And as you can see here, that right ventricular muscle creeps even into the base of the pulmonary artery and sits right around where the pulmonary leaflets are sitting. And once we harvest the pulmonary artery, that muscle becomes devascularized, it becomes necrotic, and therefore it provides no structural support to the pulmonary valve. And one of the early mistakes that was made with the Ross procedure was that surgeons would harvest the pulmonary autograft and leave about 1 centimeter of muscle below the insertion of the leaflets, and then just run that muscle along the aortic annulus, and therefore the valve would then sit in a supraannular position, and this muscle here would then, over the next few hours to days, die, and the valve sits in systemic pressures and would therefore dilate. That's what we saw in that Dutch study, for example. And so principle number one is to make sure that the pulmonary autograft has to sit in an infraannular position on the aortic side. It has to go and sit inside the LVOT so that the native aortic annulus then provides support for the pulmonary valve itself. And that is really one of the key elements to the operation. So you see, once we harvest the autograft, the first thing we do is we trim that muscle. You don't want to leave more than 2 to 3 millimeters. I like to scalp the muscle as well, as opposed to leaving a long sleeve of muscle under the leaflets. And then when we pass the sutures through the muscle and through the aortic root, here you see that the needle comes out very deep in the LVOT, much deeper than with a regular aortic valve replacement. And when you go through the autograft, you go right at the hinge point of the muscle and the cusp, so that you're completely excluding that muscle from the anastomosis. And therefore, the autograft sits inside the LVOT, and then it becomes supported by the aortic valve. This is making sure that the proximal portion of the aortic root is well supported and stabilized. Distally, the autograft has to be trimmed, leaving no more than 2 to 3 millimeters above the commissures, instead of leaving long pulmonary artery tissue, which can only dilate under systemic pressures and then stretch the sinotubular junction and cause aortic regurgitation. And finally, in patients with aortic regurgitation, it is important to further support the aortic root, either by by putting it in a graft, by doing an inclusion technique, or by doing our preferred approach, which is an extra-aortic annuloplasty, and a Dacron tube just above the sinotubular junction. As you can see here, this is the annuloplasty. We cut a ring of Dacron that corresponds to the size of the pulmonary annulus. We upsize it by 5 to 6 millimeters. The annuloplasty sutures are then passed through the Dacron ring, as you can see there. And then it is lowered into position and tied around the Hagar dilator, which is the size of the pulmonary annulus. And you can see once you've done that, it really stabilizes. It reduces the size of the aortic annulus, and it stabilizes it in the long term. And the final thing that is key to ensuring long-term durability is controlling blood pressure after surgery, not only for the first week or while the patient is in the hospital, but for the first few months after surgery. We use an app that allows us to track patients' blood pressures from the time they leave the hospital, and we aim for a systolic pressure of less than 110 for the first 6 to 12 months after surgery. Why is this important? Because we know that the autograft, the pulmonary wall, is a living structure, and therefore it adapts to new environments. The higher systemic pressures will lead the autograft wall to remodel itself. There's collagen deposition in the adventitia. Its biomechanical properties resemble more an aortic wall after a few months from surgery. But if we don't allow it to adapt because the pressure is too high, instead we will have early dilatation, and that will cause reoperation. So early blood pressure control is really key to ensuring stability. And this is an example of a patient that left the hospital with good blood pressure control, but once they got home, they started becoming a bit more active. You see their blood pressure went up. We adjusted the medication 1, 2, and 3 times, and then we were exactly where we wanted to be. For each of our patients, we have graphs like these that allow us to track their blood pressure and to correlate uncontrolled blood pressure with any root dilatation in the future. Doing a lot of these taking care of a lot of these technical principles, we can actually expect very good durability from the pulmonary autograft. This is a propensity matched analysis from the Toronto group, published by Amin again, where they looked at freedom from autograft valve intervention between the Ross and mechanical AVR. And you can see that at 20 years, there was no significant difference between the two groups. So it can really be kept very low, the rate of reoperation, if the operation is done carefully. And this is from the review. And essentially, the annualized rate of reoperation in all of these studies is around 1% per patient year range, which compares very favorably even to mechanical AVR, but certainly much better than tissue AVR in patients in that age range. My final point is, what about the guidelines? The guidelines are supposed to align evidence and recommendations in a straight line, take the evidence and make recommendations. And yet when we look at the 2014 ACC-AHA valve guidelines, and the most recent version was published a few weeks ago, the 2020 guidelines, and there has been no change, the Ross is a class 2B indication with level of evidence C to be performed by an experienced surgeon. It may be considered in young patients when anticoagulation is contraindicated or undesirable, really not reflecting the data that I just showed you earlier. And the reason I show you this is for all the trainees who are listening, is to be very critical of guidelines. You cannot just take guidelines and assume that this is what it is. This is the best evidence we have. You have to dig a little deeper into what informed these guidelines. And if you look at the evidence behind these recommendations, none of the papers that I mentioned earlier, including a prospective randomized trial, which would have taken the level of evidence from C to B, was referenced in these guidelines. So there's a definite referencing bias which influences the recommendations themselves. The 2017 valve guidelines, the European ones, went even a step further in that the word Ross procedure is not even mentioned anywhere in the guidelines. They simply focused on mechanical or biological aortic valve replacement for the choice in different age group categories. And the reason they did so, when I spoke to the chairman of the guidelines, is they say that guidelines should be are written for the majority of centers, for the majority of patients, rather than what is necessarily what they think is the best approach for a given patient, but rather what can be offered in the majority of centers. So we can debate for a long time what the role of guidelines is and how they should be written and with what purpose, but at least that was the approach, and that's why they decided to keep the Ross procedure aside in the guidelines. So I would tell you that really when it comes to the Ross, there's a definite misalignment between evidence and recommendations. And in recent years, you'll see editorials coming up. This is one that I had written with Ismail Buhut, suggesting that we need to re-examine the guidelines. And since then, others have written editorials. This is by Tyrone David. The Ross procedure is the best operation to treat AS in young and middle-aged adults. This is from the Cleveland Clinic. Is it time to reconsider use of the Ross in adults? And this is the most recent one from Mike Borger. In Germany, the Ross procedure, time to reevaluate the guidelines. So again, going back to our case scenarios, which we started the presentation with, I think my computer just froze. Let me see. I only have 5 slides left. But maybe this is a message. Let me see. Just trying to reopen the presentation. Well, it seems like it won't allow me to reopen. But in any case, I only had a oh man.
Luay? Hello?
Yes.
Luay, sorry, my computer completely froze. I'm trying to turn it back on. But bottom line, I was just saying I only had a few 5 slides left, and it was mainly a conclusion slides just to say that, just to wrap up the main message of this presentation, which is that again, in young adults, I think the looking for living aortic valve solutions, whether it's aortic valve repair or the Ross procedure, really seems to be associated with best long-term outcomes. So that was the purpose of this presentation. While my computer reloads, and I'll join again with my computer, we can maybe open it for discussion at this point.
Sure. Thank you very much, Dr. Al-Hamamsi, for this excellent presentation. And again, thank you for joining us today, early morning. So if anyone has any question for Dr. Ismail, we can start with the questions. Maybe I can start with one. So in your opinion, what do you think many of surgeons, some of them are seniors, are shying away from ROS? They will not do ROS unless it is the only option, and this usually in pediatrics group. So is it the learning curve, or despite all these good results?
I think this is a good question, and I think it's a combination of factors. The first is that there was a lot of enthusiasm for the ROS in the 90s, and many surgeons started doing ROS procedures. And as you know, the ROS is like any other complex operation. It needs to be concentrated in the hands of surgeons who are dedicated aortic surgeons who have a particular interest in aortic root surgery, as opposed to someone doing it 2 or 3 times a year. Anytime you do something like this 2 or 3 times a year, the outcomes will just not be as good as if you do it regularly. And these are young patients in whom, as I said, one expects to have very good, or should expect to have very good safety of the operation. And so anytime you have bad outcomes, it automatically puts a bit of a break on the operation. And because there was enthusiasm, many surgeons started doing it, especially in the US, leading to very poor overall results. And that really gave it a very bad name, if you want. But then again, some groups persisted with it, mainly those groups that had aortic surgeons who do, regular aortic root procedures. And now, in where we are, we're seeing the long-term outcomes of these surgeons that continue through the 90s and early 2000s to do them, and their data really speaks for itself. So I think the reason why some surgeons may not do it is there is still this lingering sentiment from that period of time when the ROS went through a huge enthusiasm and really died with one series after the next showing high operative mortality. I think the lesson learned today is, it's hard for established or older surgeons perhaps to get out of the comfort zone and to start getting into something like this. But I think for young surgeons or trainees who have an interest, it is definitely much more accessible today, and it's definitely made much safer than it was in the 90s. Myocardial protection today is very well controlled. We know how to protect the heart for 2 or 3 hours of cross clamp time without having any impact on cardiac function. And we, many of the things that we do are just better. The bypass circuits are better. We have less hemolysis. We have less bleeding. So for all these reasons, it can be done very safely. And we now understand that it has to be concentrated in the hands of aortic surgeons because there's a very close correlation between volumes and outcomes. Just like I wouldn't go do a mini mitral procedure 4 or 5 times a year, I would rather send it to someone who does this regularly. I wouldn't expect someone to do a ROS 4 or 5 times a year. So it does take a certain commitment. It does take surgeons whose main focus or one of the main areas of interest is aortic root surgery, and that can combine Bentals and valve sparing operations and aortic valve repairs and the ROS procedure. You don't need to be doing 100 ROSs a year to be considered a safe surgeon doing a ROS, but you need to be doing a fair volume of aortic root procedures so that mobilizing and reimplanting coronaries, mobilizing the aortic root, all of these things become second nature And then when you're doing the ROS, the added technical step is really very limited. It's all about harvesting the pulmonary autograft, which can be done very safely. So I think, you know, again, the older generation didn't have all the data that we today have. So it was maybe a bit harder to decide, I'll just do a ROS, but maybe have 3 times higher risk of mortality if I can just put a tissue valve or a mechanical valve and the patient leaves the hospital within a few days. But now we have enough data to inform what we're doing, especially in terms of long-term survival and quality of life, that we can't really ignore it anymore if we want to serve the patients the best way we can.
Dr. Hamam, if you allow me, I have a question. Actually, 2 questions. So the first question, in your cohort of patient, did you have to re-intervene because of the pulmonary valve, or it was like no need for intervention in those patients?
I think Dr.
Yeah, maybe trying to reconnect from the other computer.
Sorry, I'm reconnected, but I was muted. No, I was saying this is a very good question you raised, and as you saw in my presentation, I really only focused on the autograft, but you noticed that I didn't talk about the pulmonary homograft. And one of the many criticisms is that, you know, when you do a ROS, you're replacing a single valve disease by a double valve disease. And what I often say is that we're not actually replacing it with double valve disease. We're replacing it with 2 valves that need to be, well, we need to keep surveillance on them, but they're not disease valve, they're working. That being said, the pulmonary homograft will cause issues in some patients. The incidence, we just published a paper that's in press in JTCVS looking at the incidence of pulmonary homograft dysfunction. And of the almost 500 patients that were reported in that series, there were 4 patients that needed a reintervention within the first 10 years. One was because of endocarditis, which can occur on the pulmonary homograft, so on the right side. And the 3 others were because of pulmonary homograft stenosis. And what happens sometimes, especially in the first 12 to 18 months, is an inflammatory reaction which causes the homograft to narrow a bit, and it causes pulmonary stenosis to some degree. This was a prevalent problem, again, in older series, and we have adjusted to it by oversizing the homograft, by giving patients anti-inflammatories for 6 months. And that has led to a significant reduction, and using decellularized homograft, that has really led to a significant decrease in that incidence. But 3 patients required reintervention. 1 was open, and 2 of them were percutaneous. The reason why 1 was open is that although the majority of patients can be treated percutaneously, if the left main coronary artery is too close to the homograft, posteriorly there's a risk of compressing the left main when you deploy the transcatheter valve. So if you have less than 3 millimeter distance on the CT scan, you should go for open reintervention rather than a transcatheter approach. I expect the incidence at the annualized incidence of pulmonary homograft dysfunction requiring reintervention to be around 0.5% per year. So in other words, 5% of the patients at 10 years, and maybe 10% of the patients around 20 years.
Okay, thank you, Doctor. Another question. So, what do you think of this procedure as an option for a patient with infective endocarditis? Any evidence of lower incidence of reinfection also?
That's also a very important point. And in the last year, we published a paper in the European Journal looking at the use of the ROS in infective endocarditis. To answer your question, yes, I do think there's a lower risk of reinfection with the ROS because it's a living valve, because there's no prosthetic material around it. You know, I use single interrupted proline sutures to implant the autograft, but the sutures are on the outside, and there's really no dacron, no anything on the inside that can, plus because it's a living valve, it can defend itself against the infection. Although, when you compare with prosthetic valves, the rate of reinfection is rather low, so it's a benefit, but it's not a huge benefit. But I think in young patients with infective endocarditis, if you select them carefully, so you don't want to be selecting patients with huge root abscesses or patients with prosthetic endocarditis, and it's a big redo and it's a big, because then you may be doing more harm than good. But in patients that have mostly leaflet endocarditis or only a small disjunction at the level of the orthomitral curtain, or things that can be easily reconstructed, I think the Ross provides a very good option in these patients in terms of short and long-term outcomes.
Thank you very much, Doctor.
Thank you.
If you allow me for another question, if in regards to reoperation after Ross procedure, did you notice any increase in risk of mortality or morbidity? And should it be done by a surgeon who did the procedure or who is doing a Ross procedure, or any other surgeon could do this?
Yeah, that's yet another important point. And the Mayo Clinic published a paper in around 2010 or so, looking at reoperations after the Ross procedure at the Mayo Clinic, and it was around 40 patients, and their operative mortality was reasonable. I think it was maybe one patient, but then within the first year they had 2 more patients that died. One died suddenly, I think, and the other one from something else. And so they were saying that the reoperation after the Ross is a very risky procedure and so on. I haven't reoperated on enough Ross procedures to be able to give you a real sense of, in my hands, what that looks like. But I've probably reoperated on around a dozen patients that had previous Ross operations done, a couple done by me and the rest done elsewhere. And I have found it to be a pretty, not as complex as people make it sound, because the pulmonary autograft does not calcify at all. The one thing that can calcify is the pulmonary homograft, but that you can really keep it out of the way if you're working only on the left side. And if you need to replace the pulmonary homograft, then that calcium becomes a non-issue because you just cut through it and it's not a problem either. So, and I've done valve sparing operations in patients after the Ross, and I've done isolated aortic valve replacement, and I've done both the right and the left side in a couple of cases. And all of them have been rather smooth. The Paul Stelzer, who has the largest experience in the US with the Ross, is actually finishing. I invited him to write a paper for a focus issue on the Ross for the Annals of Cardiothoracic Surgery, reporting his experience with redos. And he's redone 91 Ross procedure with an operative mortality of 1 patient out of these 91. So yes, I think if these operations are done, just as much as the Ross procedure itself should be done by surgeons who have a dedication to aortic root surgery, I think a redo after a Ross should definitely be done by an aortic root surgeon. It doesn't have to be a Ross surgeon, but certainly someone who does aortic root surgery regularly enough. And if that is the case, I think it can be done with good safety outcomes.
Do you have any experience with valve and valve for the autograft, like TAVI and?
Yeah, the problem with that is that the autograft, the mode of failure of the autograft is not calcification and stenosis. It's rather either autograft root dilatation and regurgitation, or primary valve regurgitation because one of the leaflet prolapses but there's very seldom any calcium on the leaflets. And so with the current technology, it's impossible to anchor these valves in that position. Maybe with the valves that they're developing for AI, that may be an option in the future, but certainly with the current technology, there's nothing that can address it percutaneously, which is not the case for the right side. The approach of choice would be a percutaneous approach, and only if anatomically it is not suitable, then we would go for open surgery.
Thank you, Prof. I have one question, if you allow me.
Of course.
Thank you for your time and this early morning. This is Abdulaziz from King Fahd Medical City. I have one comment or one question regarding the ROS. The outcome of ROS in case of bicuspid aortic valve, especially in era of many great prostheses. So any comparable between ROS and that prosthesis? And the other question, the outcome of ROS in acute acute pathology of the aortic valve.
So, thank you, Abdulaziz. In terms of the ROS in bicuspid aortic valves, because these are younger patients, the majority of these patients are under the age of 60 at the time of operation. The majority of patients in all of these studies that I showed you, including in my own series, are patients with bicuspid or unicuspid aortic valves. So there are very few patients with tricuspid aortic valves who actually end up undergoing a ROS, because typically these patients will present later in life, and at that point the benefit of the ROS becomes more marginal. Is there any direct comparison of the ROS versus prosthetic AVR in patients with bicuspids? All the studies that compare ROS versus prosthetic AVR are studies that are either propensity matched analysis or meta-analysis. There's no prospective randomized trial that has compared the ROS to a prosthetic aortic valve replacement. So all we can do, unfortunately, is to extrapolate and draw conclusions and try to be as rigorous as we can with all the statistical methodology to be able to compare apples and apples. But there's no doubt that there's always a selection. There's an element of selection bias, and there's an element of who does these operations in one arm and the other. There's an element of patients who have a ROS procedure will be followed more closely over time than patients in whom you put a prosthetic valve, and maybe that contributes to their doing better in the long term. So all of these are things that can influence the data that I showed you. But no, there's no prospective trial. There is one that has been started by a group in Hamilton, but I have strong reservations about the validity of the study design because of how long they'll be following these patients, and because of the centers that are doing it, or at least the inclusion criteria for surgeons who participate. And I mean, there are many methodological issues with that trial that make me a bit, a bit skeptical about the value of it. But it, if it can address the question, then why not? But certainly right now it's more retrospective. In terms of acute presentations, with infective endocarditis, we just mentioned it. With acute dissections, I wouldn't do a ROS. In fact, I wouldn't do a ROS in any patient with a connective tissue disorder, or any patient that has aortic dilatation and a family history of dissections, because that may suggest that that patient has a connective tissue disorder, an underlying connective tissue disorder. So, and of course, if the patient himself has a dissection, I wouldn't consider doing a ROS procedure. Are there any other acute conditions for the aortic valve? I mainly think that dissection and endocarditis, unless you had other things in mind.
That's it. Thank you, Dr. Ismail.
Thank you.
Any other question? We have Dr. Farid Khogir with us in the audience. He's our Program Director at King Faisal, and he's the head of Scientific Committee of the Cardiac Surgery Residency Program. I'm not sure if you have any comment, Dr. Khougi.
Yeah, thank you, Luai. Thank you, Ismail. It's good to see you again. Just to reintroduce myself, I worked 40 years ago with Dr. DeBakey and Dr. Crawford. And then when I got back here to Saudi, I worked with Duran, and we invited also Dr. Carmetier and Dr. Cabral. So those with these big names, and the Ross has been here for quite some time in our hospital. Unfortunately, we still have not so good results, and most of this, unfortunately, did not make it to the published literature. Maybe just like you said, there is some instance of connective tissue disease, genetic diseases that we're not aware of, or rheumatic heart disease that may be also still related to connective tissues. But regardless, I really enjoyed your speech to our residents. They are very bright, and they have went through a lot. They have a 7-year program, and many of them have done very well with the USMLE. So the question to you is, are you willing to take any of those residents? I see 2 of them have already, kind of developed them somewhere in Toronto and somewhere in Montreal. But would it be a chance that we can send you fellows after they get their graduation?
Yeah, thank you, Dr. Farid. Very nice to see you virtually here. Of course, I would be very happy to have fellows for aortic surgery here at Mount Sinai. That would be a great pleasure for me to do that and to build further relations between here and Saudi. I would be very, very happy to do so.
Wonderful. Thank you very much again for your time, and thank you for your presentation. I really enjoyed that.
And thank you for being here. Thank you for your comments, and thank you for attending.
Right.
Okay, since there we have no other questions, I would like to thank again Dr. I can see one hand, Dr. Hassam. Any question?
Yes, good afternoon. Thank you, Dr. Ismail, for the great presentation. This is Hussam from National Heart Institute, Cairo, Egypt, and I'm practicing now in King Fahd Medical City. Thank you for your time and for the great presentation. And I would like to ask you about the aortic valve repair. Do you have any take on Ozaki procedure?
Thank you, Hassam. This is a good question you ask, and I think the Ozaki procedure is a very good idea in old patients, because in any case we're implanting a pericardial prosthesis. So pericardium for pericardium, it makes sense. And in this case, we would be implanting it without the stented ring, so perhaps even improving hemodynamics over a stented bioprosthesis. For younger patients, I'm much more skeptical about the role of the Ozaki procedure. Remember, Ozaki's data and series is older patients, and for some reason that it created such excitement that people extrapolated that data and are assuming that we can get similar results in patients 30 and 40 years old. But I think, all the data over and over and over again has shown that the minute you put patch material or pericardium in the valvular positions on the left side, they very quickly calcify, retract, and fail. So at least I fail to understand what we have done differently in terms of, or why we're expecting a different result when we're doing the same thing with the Ozaki. The patch material we're using is very similar. I mean, there hasn't been much progress in that sense. So, I think it's an exciting thing to be able to offer to patients, but I don't know that it's necessarily the best thing to offer to patients in their 40s or 30s. again, I only trust evidence and numbers and data. So I stay open-minded so long as people who are doing it are following these patients longitudinally and not just saying that we can do it safely and look at us and we're so excited and we do Ozaki, and that's not science, and that's not serving the patients the right way. We need to we need to follow these patients, and at 5 or 10 years start saying, okay, this is what worked, this is what did not work, and maybe there's a role for it. But right now I'm watching from the sideline and hoping that some of the groups will actually do more than just say we offer Ozakis in patients, but rather tell us we're following Ozakis in patients, and this is what we're finding. So I think in 30, 40, 50-year-olds, I'm not sure it's a very good idea. In little kids, it may be a good option to delay the Ross procedure. It will make for a very easy reoperation, and if it can buy the kid 4 or 5 years, why not? That's, there's a big difference between a 10-year-old and a 15-year-old. But I don't think there's a big difference between a 30-year-old and a 35-year-old. It may be that we need to, think of alternatives. But again, I don't have data. The data is not out there. I hear a lot of excitement and it always comes up, but I'm a bit skeptical.
Thank you very much. Thank you. Appreciate your time. Thank you.
Thank you.
All right. Thank you very much, Dr. Ismail, for joining us today. And we hope next time we'll be live in Riyadh in the near future, inshallah.
Shukran, inshallah. Well, thank you everyone for being here this morning or this afternoon and over there.
All right. Thank you very much. And by this, we'll conclude our.
Okay. Bye-bye.